All right, so airway management. So one of the things we do a lot of, and remember that is our A in ABCs. So one of the things we take care of first. And there's a lot of things that we can do from the advanced level to higher levels that we go, even BLS, to really secure that patient's airway the best we possibly can. Because remember, we talk about perfusion, oxygenation, all this stuff, and that really is making sure the airway is patent. Because without that, the patient will die. So we really need to focus heavily on how we're going to stabilize and manage this patient's airway. That's kind of what we're going to cover tonight. There we go. So the competencies 1 through 6. So obviously airway management, respiration, artificial ventilation, going back to BVMs, and kind of a quick review of what we do at the BLS level. Because whether being a paramedic to EMT, really it starts with the basics, right? We cannot forget where we came from, where the basic level is, because we're going to start with the simple adjuncts, OPAs, NPAs, and then really, managing that area with a solid BVM. We're not talking about ventilators. We're not going into any of that kind of stuff at all, right? We're talking about the true bag valve mask and how we're going to really secure that airway, and also suctioning and things like that we need to worry about. So we have to cover airway anatomy. So having an idea of what the airway looks like and what you're playing around with will really help you understand not only where things are, but also understanding if we're giving medications. And that goes into the next part here. I'll say airway assessment techniques, but this part here, right? That pen's not working. Really, we're looking at this right here, pathophysiology of respiration. And we can give medications to change that. So I'm sure you guys had a chance to digest a little bit in regards to Tuesday's lecture on patient assessment and then the capnography lecture afterwards. Hopefully that was all useful information for you, because it's going to come back to haunt you in this slide here. We start talking about aspect balance and airway management. So it's kind of like the precursor of what you guys are going to be getting into, but also learn some new waveforms to look at. So if anybody used capnography between now and then, I'm sure you guys probably saw it on the screen and said, "Oh, I know what that is." I hope. And then also looking at the pulmonary ventilation and oxygenation. That's another huge part. We're going to go over external, internal, and cellular respiration, supplemental oxygen therapy. Remember those numbers as far as percentages, that we can't forget those. And assessment and management of adequate and inadequate respiration. How do we fix that? Assessment and management of adequate and inadequate ventilation, like artificial, minute, and alveolar ventilation. We're also going to talk about the effect of artificial ventilation on cardiac output, which you can find on page 590 in your book. And then obviously pathophysiology is what applies the comprehensive knowledge of pathophysiology of respiration and perfusion to patient assessment and management. What we do has a cause and effect. What we do to a patient's body will have a change, right? And what will that change be? What is your predicted outcome if you give a medication, and what we're looking for in a reassessment? But not only what we're looking for, what it does to the body. So having the understanding of the alphas, the betas, beta 1, beta 2, alpha 1, the things that we're giving that will have changes as part of that mechanism of action with the medication that we give. So the most important steps in caring for any patient are obtaining and maintaining a patent airway and ensuring that the patient is breathing adequately. That is the key. Without it, we can't go any farther. Promise if they're bleeding out, we stop the bleeding, right? But if we can't manage an airway, we can't get into circulational stuff and things like that. We can't really get into the IVs and all that fun stuff that we want to play with, because they're going to die if we don't maintain it, right? So oxygen reaches body tissue and cells through breathing and circulation. We're going to dive deeper into this in the anatomy review here. So the respiratory system consists of all the structures in the body that make up the airway and help us breathe or ventilate. That's the respiratory system. The airway is divided into the upper and lower airways. We're going to show you that difference between upper and lower in the next slide. And then the structures facilitating oxygenation and ventilation include the diaphragm, right? How our muscles contract and relax, causing ourselves to be able to breathe. Muscles of the chest wall, accessory muscles of breathing. We talk about accessory muscle use. We can actually see that in the patients that have severe respiratory distress, or nerves from the brain and spinal cord to those muscles. And then also ventilation, remember, is the exchange of air between the lungs and the environment. That's ventilation. So how you take air in and back out as carbon dioxide. So looking at this slide here, right? So we have our upper airway here, nasopharynx, nasal air passages coming through, oropharynx, the mouth, the epiglottis, and the larynx. At that point in time, we go into our lower airway. So this marking right here is where it separates upper versus lower. What is this space called here in airway management, other than upper airway? What kind of air does this hold? Do you guys remember? You want to take a shot at it? So dead space, right? So in that area, there is no CO2, right? That's why we don't get that reading. The CO2 comes from down here in that exchange. Okay. So our lower airway has the trachea, the apex to the lung. Okay, this is the apex being the top of the lungs here. So we're listening to the apices. That's what we're talking about. The carina is where the trachea comes down and splits between the right and left main stem bronchi. So the carina is here, right? Then it branches off. The base of the lungs are down low. The main bronchus, right, left main bronchus, go into the bronchioles, which are here, the bronchial trees. And all that will then branch off into the alveoli. And then the alveoli are your pulmonary capillaries. And that's where that oxygen CO2 exchange is happening. Now, if these are off-gassing wrong, if they are, we're going to see what type of waveform. We start seeing the constriction here in the bronchioles. These are off-gassing at different rates. And we start to see that waveform that looks like this. What's that called? That's a bad drawing, I apologize.
Shark fin.
Yeah, the shark fin waveform, otherwise known as bronchoconstriction, right? And that's where that's coming from, is in here, is down here in release, right? So to kind of look at the anatomy review, if we're giving a medication called a bronchodilator, which would be what two medications that we could administer?
Albuterol and Duoneb.
Yeah, albuterol and Duoneb. These bronchioles will start to dilate, bronchodilation, causing the exchange of air versus carbon dioxide to become normal, which will in turn give us our waveform be like this and not like this down here. Right. So that's what we're looking for, is to have that changeover. So understanding when we're giving a medication, this is what we expect to see from this change, right, to this change, allowing for good gas exchange. And this in turn will help with oxygenation, and that will start increasing our SpO2. Okay, which also, if they're breathing fast, it will start increasing our end tidal from that lower range, right? The hypercapnic range that we're talking about. So the upper airway is the major function of the upper airway, is to warm, filter, and humidify, right, air brought into the body. Like, I'm trying to show you a little bit more on the next slide for this, the cilia and whatnot, and the nares. But the major function of the upper airway is to warm, filter, and humidify. You'll probably see that again on a quiz, all right, in exams and national registry and all that stuff. Air brought into the body. The pharynx is composed of three parts: nasopharynx, oropharynx, and laryngeal pharynx. Remember that the larynx is also considered the dividing line between the upper and lower airways. So looking here, right? So what we have I'm trying to sort of decipher all this here really quick. So we have our nasal cavity, the hard plate or hard palate, and soft palate. Why is this important here? Something you guys do as a BLS provider when you insert something.
Okay.
OPA, right? So when you're placing an OPA, you go from hard palate to soft palate. That's when you make your 180-degree turn and drop it into the airway. Okay, that's why it's good to have an idea what those are. This is your entrance to the auditory tube. So if the eustachian tube comes up through into the ears. Your pharyngeal tonsils are back here. Looking at here, this is the uvula. Little looks like I'm trying to draw a blank. Never mind, we'll just go over this. It's uvula. We have the tongue here, the lingual frenulum, vestibule, gingiva. This is your hyoid bone. You might see this on a quiz sometime, but name the only bone that's not connected in a bone in the body. This one here. Your tonsils and your epiglottis. All right. Oh, I didn't want to do that though. Go back here. So important things with this right here. Epiglottis is good to pay attention to. With kids, you have something called epiglottitis. And that's where this starts really inflaming. All right. On an x-ray, kind of side topic, on an x-ray, you have something called thumbprint sign. You guys don't need to write that down. You know, read a bunch of quizzes on that one there. But thumbprint, it looks like a thumbprint, like pushing against the airway in the trachea coming down. We have our nasopharynx, which is here from this point to this point. We have our oropharynx, and we have our laryngeal pharynx coming down lower. All right. So any questions on that part so far? Kind of a quick review. Good anatomy review. All right. So the nasopharynx is formed by the union of facial bones. All right, sorry about that. So formed by a union of facial bones, divided by the septum, and lined with a ciliated mucosal membrane. Remember I mentioned the cilia that helps filter that air. All right, so cilia that's there. The cilia helps move contaminants out of the body as well. Turbinates, and hopefully I don't see another picture of it coming up, but there's multiple turbinates that increases the surface area of the nasal mucosa, which I can show you guys what it looks like. Sinuses are cavities formed by cranial bones. Remember, you have a lot of pressure there, like sinus pressures, things like that. Fractures of certain small sinus bones may cause a leakage of cerebrospinal fluid into the nasal passageways or auditory canal, right? So our CSF again is stored where? In what space? Jen, I think you got that one. You just made that face.
Yeah, the arachnoid space.
Yeah, the subarachnoid space, exactly. So the tissues of the nasopharynx are extremely delicate and highly vascular as well. Unfortunately, there's no photo on here at all that actually shows the turbinates of the nose. Right. So the oropharynx, which is part of the throat found at the posterior of the oral cavity. The epiglottis is a leaf-shaped cartilaginous flap located at the base of the tongue and above the larynx. So what's important about that epiglottis? What does it do? The flap, it moves back and forth, right? So if you eat food, it blocks the
Airway.
Airway. If you're breathing, it goes over the esophagus, right? Kind of blocks things for you. All right. So this is the larynx, formed by many independent cartilage structures. So the main laryngeal structure is the thyroid cartilage, which sits right here. This whole big area, right? The glottic opening is the narrowest portion of the adult trachea, right? The glottic opening. Now, these are cartilaginous rings of the trachea, these blue parts you're seeing here, okay? In a pediatric, those don't really exist yet, right? Which allows the trachea to become more pliable. So it'll start bending, and when you bend it, it crimps off. Or in an adult, it doesn't do that because the cartilaginous rings go around the trachea. The cricoid-thyroid membrane, so this area right here, is important really for paramedics. This is where a crike's going to be done. When they do a surgical crike, what they'll do is they'll come in and they'll cut down and then a little bit over, they'll spread it, and then they'll put a tube inside. Okay. Or they can do needles in there too as well. But the cricoid cartilage is down below. This right here be like your Adam's apple. So as you're feeling in your neck, everybody wants to try it. Run down the trachea here, you'll feel a little indent. The indent is where the cricothyroid membrane is located. So for those of you who've been involved in EMS for a while and have had to work with a paramedic, and they say, apply cricoid pressure for the intubation. We don't do that anymore really, but some older medics still do it. It does serve a purpose from here and there, right? They're talking about applying pressure here. What that does is it helps align that trachea better for them to get the intubation, in theory. I've done it before. It does work. It's just there's other methods now of intubation using other like bougies and video scopes to make things a lot easier. But the glottic opening, the narrowest portion of the adult trachea, it's the narrowest spot. The glottic opening is the part that sits right up in here, and that's where an intubation tube would go through, that glottic opening that's there. All right, next slide. So the function of the lower airway is to exchange oxygen and carbon dioxide. That is its main function. Getting O2 in, CO2 out. The external boundaries of the fourth cervical vertebrae in xiphoid process. The trachea, otherwise known as the windpipe, is a conduit for air entry into the lungs and divides at the level of the carina. Remember the carina being where it splits off and it comes down and splits like this, or the right and left mainstem, as we can see here. So the carina being here, and it branches off right and left mainstem. Then it goes into the bronchioles, and it branches off, branches off, branches off. And at the end of those are your alveolar sacs at the end. So if you're in the back of the ambulance and a paramedic intubates and they say, take a listen to the lungs. Okay, remember, looking at this photo, this here, right, is the right side. This is the left side. It's opposite. We look at the patient. What's going to happen is if they intubate too far, it goes down and it deviates to the right. It's called a right mainstem intubation. So if you don't hear any lung sounds here, and you have good lung sounds over here, they may have to pull back on the tube a little bit. And they may tell you to listen. It's kind of a helpful hint, right? That they go too far in, it goes right mainstem, and you won't hear lung sounds in the left, or you'll have very diminished sounds, right? But again, so it goes to the bronchi, into the smaller bronchi, into the bronchioles. After the bronchioles, now we have our alveoli. Each bronchus divides into small bronchi. It goes in the bronchioles. Bronchioles then branch into the alveolar ducts, right? And the alveoli serve as a functional site for exchange of oxygen and carbon dioxide. But what's important about this here? We're going to cover that in the next slide. But what happens? Do they kind of sit still? Do they get bigger and smaller? Do they have elasticity to them or no?
Yeah, they have elasticity to them. They get bigger and smaller.
Okay. So what happens if they lose that surface tension and they don't have that elasticity anymore?
Gas exchange is difficult. They're not getting the oxygen.
Exactly. And Jen, this is what happens next. Atelectasis happens, and then the alveoli collapse. This will turn into a pneumothorax eventually. So oxygen diffuses through the lining of the alveoli into the pulmonary capillaries. Surfactant lines the alveoli. So that's something you need to pay attention to is surfactant, right? If you lose surfactant, what it does, it decreases surface tension, therefore allows for elasticity to expand and contract. If we lose that surfactant, it goes away. Atelectasis happens, and you start seeing alveolar collapse or collapse of the alveoli. Right. So the amount of surfactant is inadequate. The alveoli are not inflated. They will collapse, resulting in atelectasis. So between the lungs and the space called the mediastinum, which is surrounded by the tongue and connective tissue. Okay. So the mediastinum kind of trying to draw it out with the mouse this time. Right in that area. Okay. Between the lung, mediastinum, surrounded by connective tissue, the phrenic nerves innervates the diaphragmatic muscle, allowing to have it contract. Right. So between the lungs and the space called the mediastinum, which is surrounded by tongue connective tissue, contains the heart and great vessels, the esophagus, the trachea, the major bronchi, and many nerves. That's why I was kind of trying to draw it here. Now, it kind of goes down a little bit farther than that. I just don't want to draw it. It kind of sits in the, oh, that's bad. All right. So what will happen is sometimes air can trap, right? And we'll have air trapping like all through here, right? Which is bad. This is what they call a pneumomediastinum. Okay, when you have air trapping in here, which we don't want. Remember, your aorta sits in here, your great vessels and all that, the bronchi, the lungs. Here's your heart down here. The superior vena cava, the inferior vena cava. Oh, wrong button. The inferior vena cava will be down lower. Inferior, superior coming in. All right. So any questions on that at all? All right. Pay attention to mediastinum. Important to know. Physiology of breathing, respiratory and cardiovascular systems. Remember, they work together. So they ensure the constant supply of oxygen and nutrients to every cell in the body. So you want to ensure that carbon dioxide and waste products are removed from every cell in the body as well. That's part of breathing. Respiratory and cardiovascular system, they have to work together. We have to be able to measure that. We can measure that through SpO2 as oxygenation and end-tidal CO2 for perfusion or off-gassing of carbon dioxide. So sufficient external ventilation and perfusion are required to deliver adequate oxygenation, right? We have to make sure we're getting this oxygen to the tissues of the body. Remember that here, time is crucial, right? 0 to 1 minute, cardiac irritability. Your heart is getting pissed, all right? We have no oxygen for over a minute, cardiac irritability, we start seeing arrhythmias. Arrhythmias are not a normal sinus rhythm. PVCs, PACs, things like that. Things that the heart doesn't like. Okay, we'll cover more of that in cardiology. I don't want to get too in depth with it now. It'll take me another 45 minutes or an hour to discuss it. So we'll do that in cardiology. But 0 to 4 minutes, brain damage, not likely at this point. But again, now your heart's getting even more pissed off. For 4 to 6 minutes, brain damage is now possible. 6 to 10 minutes, brain damage likely. If you're without oxygen for more than 10 minutes, irreversible brain damage. 10 minutes is not a long time. So how important is it to manage that airway when you guys get on scene? The patients have to be managed. They have to have oxygenation. They have to have perfusion. You can oxygenate all day long, but if you can't perfuse, that also means trauma by patient bleeding out because we don't have hemoglobin to transport oxygen. We're not really perfusing the cells, which puts them into a shock-like state. If they are oxygen deprived with nothing at all, time is ticking and you don't have long. So when you get on scene as clinicians, you have to make a clinical decision to start treating rapidly for these patients that have significant breathing issues because they are pending failure. If you see someone in severe respiratory distress, and I'm talking respiratory rate in the 40s, pale, diaphoretic, accessory muscle use, pursed lip breathing, tripoding, SpO2 in the 60s, end tidal 18, because they're breathing they're so tachypnic. These are patients that don't have much time. And we see these a lot with our severe asthmatics. We see this a lot with our COPDers that have an exacerbation of COPD. These are patients that if they can maintain their own airway and their blood pressure isn't like 60 over nothing, they're going to get CPAP. These patients need that crutch because CPAP reduces mortality, reduces intubation, right? So we're going to put them on end tidal. We're going to put them on CPAP. We're going to put the FiO2 to 100%, which it should be anyways. We're going to set our PEEP to 5, and we're going to work our way up to 10 to 15 to 20. And within our protocols, we go up and we go up and we go up. All right, now we hear wheezing. We're starting to oxygenate better. We have to bronchodilate. We do not take that CPAP off. Now we inline these NEPs. All right, so we run a second oxygen tubing to a canister, nebulizer canister that's hooked inline to the piece in their face right here. You hook it in, squirt the medication into it, let it aerosolize, and now we're pushing that medication in deep. We're allowing for true bronchodilation, right? But what do we expect with that? Now they're already in a shock-like state. Their physiology of breathing here, the time is critical. What's already increased now? They're shocked, so what's increased? We already know respiratory rate is. What's the other one? You guys know this. I know you do.
Heart rate.
Heart rate, exactly. So now our heart rate's going up and we're giving albuterol. Albuterol is a beta 1, beta 2, right? So what does beta 1 do to the heart? Go up. Increases heart rate and bronchodilates. Beta 2, 2 lungs, beta 1, 1 heart. Right? So we're increasing heart rate now. So we expect to see that. But I'm willing to sacrifice some tachycardia to bronchodilate because eventually all that's going to come back down again and meet homeostasis. The patient's tachycardic and tachypnic because they can't breathe. By breathing faster brings in more oxygen, but in turn retains too much carbon dioxide or blows off too much carbon dioxide, not retains it, blows it off. The heart rate goes faster because now it's going to try to pump that oxygen on the hemoglobin through the cells faster as well. So our body's trying to compensate its shock, right? Even if it's respiratory, it's still compensation. We're going to see decreased end tidal, tachypnea, right? Hypercarbic. And now we're giving a medication to help reduce all of that. But there's going to be some side effects. You guys get what I'm trying to say? These are sick patients. Patients that can't breathe struggle. When they become hypoxic, they become anxious. So now you have an irritable heart, the patient is anxious, who can't breathe, and you're trying to calm them down. Right? One of the tricks that I learned a long time ago with CPAP, is let the patient self-administer it, because people can become very claustrophobic when they can't breathe. Have them hold it to their own face and see that it works. Right? Within minutes, you're going to start seeing you should start seeing marked improvement, unless they've gotten past that point where they can no longer use accessory muscles and they can no longer breathe. Right? Those are the ones you should be scared about, because those are the ones you need paramedics for, because they're going to get intubated. Those patients that are pending that failure, and if they've been in failure so long, paramedics, well, we carry all these medications. We have mag sulfate, we have solumedrol, we have Decadron, all this cool stuff at our disposal, right? But I can't give mag to a patient who no longer can use their smooth muscles anymore. If they're already relaxed, they're relaxing even more, they can't breathe. But yes, get paramedics coming, but be ready to start bagging that patient. When CPAP no longer works, we go to that bagging. We end up using a BVM, because this time is ticking here. We're getting to that point. We're trying to put that crutch in. We're trying to support it to the best we possibly can. But you've got to pick up on those signs and symptoms early. If they're in distress, what can we do? Right? People are like, oh, CPAP, critical patient. People wear CPAP at night to sleep for sleep apnea. Right? You got to do what's best for your patient. What do they need? Now, if any of you guys in the class so far ever applied CPAP to a patient on your own, you've done it. Okay. The first time someone puts it on can be a little scary if you've never used it before. Right. But again, it's not so scary for as much as for that as it is for the patient. And you've got to calm them down. You've got to control that. Right. That helps with that physiology and breathe. That's why I was saying on the slide so long is it's so important to pick up because once we start hitting these numbers, right, irreversible brain damage in 10 minutes, I've got 3 minutes to make a decision. Am I going to CPAP this patient or not? Or can they get a non-rebreather? Just because their oxygen levels are low does not mean they require a non-rebreather. They may require a CPAP because they can't breathe. Okay. So look at what the patient truly needs. That's why I said protocols tell you stuff, which is great. I want you guys to be clinicians and think about why you're doing what you're doing. Not just because the book tells you to do it. And the book's usually pretty much right. But if you follow just the book and you have an idea of what's going on underneath on a physiology level, a pathophysiology level, it makes it difficult for you to continue your treatments. Right? So look at what the patient's actually doing. So ventilation is a process of moving air into and out of the lungs. Inhalation is active muscular part of breathing, where air enters the body through the mouth and nose and moves into the trachea. The diaphragm and intercostal muscles then contract and lungs then fill with air. The ability of the lungs to function properly is dependent on the movement of the chest and supporting structures, the thorax, the thoracic cage, the diaphragm, accessory muscles. Those are all part of your ability for the lungs to function properly. They have to have good movement. So the diaphragm is a specialized skeletal muscle where functions both as a voluntary and involuntary muscle together. So what if we have issues with the diaphragm? Let's go into cardiac arrest for a minute. You got that brand new EMT who's never seen a cardiac arrest before. They get there, they're all excited because they get to see their first code. You tell them, okay, manage the airway. I'm going to start CPR. And OPA is put in, right? They put 2 NPAs in for good measure because they're all excited to get the place airways, right? And they're ventilating away. And they're doing this. Where's all that air going?
Belly.
The stomach.
The stomach, right? And it starts getting, you're like, man, this guy's putting on a lot of weight, right? The stomach just keeps growing and growing and growing, which is not a good thing. And this is why. If you start filling in your stomach, what is happening to the diaphragm? Think about it. What does it do? Your stomach's getting bigger. Interesting. Your stomach's getting bigger and bigger. Therefore, putting pressure on the diaphragm in this direction, causing pressure against what? Hint, what are you compressing when you do CPR?
The heart.
The heart, yes. This is not simple. This is very simple stuff. If the diaphragm is being pushed because you have an overinflated stomach because of an EMT who's bagging 100 times a minute, you're not going to be able to pump the heart effectively. It's just not going to work, right? That's why when paramedics come in, they should, in any cardiac arrest, they should automatically be putting in an NG tube and deflating that stomach. That's very important, okay? All right. So next part about ventilation. The partial pressure is the amount of gas in air or dissolved in a fluid such as blood. It's measured in millimeters of mercury. So the body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Okay. The atmospheric pressure is normally higher than the air pressure within the thorax. So during inhalation, a slight vacuum is created. Gases such as oxygen will then move from the area of higher pressure to an area of low pressure, right? Which is called diffusion, until the pressures are now equal on both sides. Right? The entire process of inspiration is focused on delivering oxygen to the alveoli. So variations of tidal volume, respiratory rate, or both will affect minute volume. Okay. As you can see here in these photos, describing what I just mentioned to you guys. Exhalation is a passive process that does not require muscular efforts. All right. The Herring-Bauer reflex is a feedback loop that prevents overexpansion of the lungs by terminating inspiration. It's called the Herring-Bauer reflex. Right? Take note of that. When the size of the thoracic cage decreases, air in the lungs is then compressed into a smaller space, increasing air pressure. Right? Maximum expiration occurs when the diaphragm and intercostal muscles relax and air is then exhaled forcefully as opposed to a normal passive process. All right, so regulation of ventilation. This involves a complex series of receptors in the feedback loops. We're going to get to this in a moment here. All right, so the drive to breathe is based on pH changes, right? So our pH being normal would be what? You need to know these numbers.
7.35.
That's our normal range, okay? In healthy people, when oxygen levels rise, the respiratory center suspends respiration until a rising carbon dioxide level stimulates the respiratory center to go, right? So the drive to breathe is based on pH changes in the blood and cerebrospinal fluid, right? So it's really, we base it on carbon dioxide. And it just so happens we can measure those levels with end-tidal. So oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. This starts that transport process. So adequate oxygenation is required for internal respiration to take place, right? Internal being the transport of oxygen to the cellular level, right? If we don't have hemoglobin, so patients in hemorrhagic shock or bleeding out, we are not going to have the ability to oxygenate and do internal respiration. So internal oxygenation is not going to happen at that cellular level because, or it's going to be diminished because of the lack of red blood cells. Right. So as far as respiration goes, metabolism, which is cellular respiration, right? Cells then take energy from nutrients through a series of chemical processes. Each cell contains nutrients and oxygen and produces energy and waste products. Okay, so each process of exchanging oxygen and carbon dioxide occurs by diffusion. So we already talked about this, we've hit this quite a bit. Oxygen comes in, waste product is carbon dioxide, that's stuff that we exhale, and we can monitor that via end-tidal CO2. So external respiration is the process of breathing fresh air into the respiratory system, right? Air from the outside coming in, exchanging oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. So looking at the photos here, right, we have the pulmonary venules coming in. You can kind of see it red on red, right? Exchange is happening here, right? Our cells are being oxygenated, and then the blue part here, the pulmonary artery, arterial alveoli, deoxygenated here, comes back out, and it starts to cycle all over again. The alveolus here, in and out through diffusion. Remember, area of lesser concentration to greater concentration, so everything equals out on both sides. This is how we get that homeostasis. All right. Perfect. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. So as you can see, internal happening here. Here's your tissues and cells all through here. Right? You can see that oxygen is being pulled through diffusion, so they're equal on both sides. As it expels, here comes the bad stuff, the waste products coming back out, pushing back out here, going back through the pulmonary process. Right? This will end up going back through the superior and inferior vena cava. Right? So it comes up and around this way. It comes down from the bottom. Right? Let's say this is the heart here. All right? Here's our chambers. It's kind of a horrible picture, but right here's our right atrium, right ventricle. So it's coming back through now into here, right atrium, right ventricle, into the pulmonary arteries, deoxygenated. Right, it goes into the lungs. At that point in time, we have our gas exchange, bad stuff out, good stuff comes in. The oxygenated blood goes through the pulmonary vein into the left atrium, left ventricle, into the aortic, ascending aorta, aortic arch, hitting the subclavian, the other arteries on top, major vessels of the brain. Those are the brain and everything else. On the upper extremity, circles back around into the descending aorta to the renal arteries, femoral arteries down below. Right? That is internal respiration. It's all happening. It's going down through, and it's hitting all the capillary beds within the body, and it's causing systemic circulation, right? Systemic oxygenation. So, any questions on internal respiration at all? You guys good? I can't see any pictures. I apologize. The only one on there now is Owen, and he has no camera. I'll make sure you guys got this. Feel free to unmute and have a conversation with me. Is anybody still there?
Here, we're doing pretty good.
All right. Okay. So respiration. So aerobic respiration. Oh my God, I can't speak today. Aerobic metabolism, right? So in the presence of oxygen, the mitochondria of the cell, which is what part of the cell again? I think Jen said this last time. What is it?
It's the powerhouse of the cell.
That's right. Flexing its muscles, it's ready to go. Right? The mitochondria of the cell converts glucose into energy. So glucose turning into energy using a process known as aerobic metabolism. Energy in a form of ATP, which is adenosine triphosphate, is produced through the Krebs cycle. And oxidative phosphorylation. Phosphorylation. Anaerobic metabolism occurs when oxygen is not present and cannot meet the metabolic demands of the cell. So glycolysis results in less ATP production. So adequate levels of perfusion and internal, sorry, let me rephrase that. Adequate levels of perfusion and external ventilation must be present for aerobic internal respiration. Right, so you have to have those for part of respiration. I'm going to go too in depth on that. That's getting more into paramedic stuff. All right, so neural control, which originates in the brain and brainstem. So the primary control comes from the medulla and the pons. Right, those are your primary control. One thing to remember when we talk about medulla, pons, and spinal cord as well for breathing. If you keep this in the back of your head, C3, C4, and C5 keep the body alive. That's what really runs your respiratory center. So if you have a patient with a cervical spinal injury and you sever the spinal cord up there, they no longer can control their breathing. It's kind of a side note on that. Right? Medullary respiratory centers control the rate, the depth, and the rhythm of breathing and a negative feedback interaction with the pons. Right? So the apneutic center of the pons is a secondary control center if the medulla fails to initiate respiration. Right? So pneumotaxic center has the inability or inhibitory influence on inspiration. So respiratory rates result from the interaction between the apneutic and the pneumotaxic centers. That's how our rate results from that, from those two. So in times of increased demand, the pneumotaxic center decreases its influence, right? So if they have an increased demand, that starts reducing. I keep track of time. As far as chemical stimuli go, chemoreceptors modify respiratory rate and depth. So we're going to constantly monitor the chemical composition of bodily fluids or body fluids. The central chemoreceptors monitor pH of the CSF and are located adjacent to the respiratory centers in the medulla. An increase in the acidity of CSF. So now remember, carbon dioxide is starting to build, becomes acidic, triggers a central chemoreceptor to increase the rate and depth of respiration. Right? So chemoreceptors in the carotid bodies of the aortic arch measure the amount of carbon dioxide in atrial blood. Chemoreceptors located in the aortic arch and carotid bodies also respond to decrease in PaO2, arterial oxygen, partial pressure, which is back up to the primary control of ventilation. And when serum carbon dioxide or hydrogen ion levels increase, chemoreceptors stimulate the dorsal and ventral respiratory groups in the medulla to increase respiratory rate. All right. You guys want to hang on 1 second? I got a call from work coming in. So stand by. Actually, you guys, since it's 6:50, you guys want to just take 5 minutes? I'll come right back. All right, everybody back? It's been close to 5 minutes. All right. Oh, that's why. Okay. That's better. Now we can continue on. All right. So as far as chemical stimuli goes, kind of finish up on this. Dorsal respiratory group is responsible for initiating inspiration based on the information received by the chemoreceptors. So ventral respiratory group is primarily responsible for motor control of the inspiratory and expiratory muscles. Those are our dorsal respiratory group. All right, so pathophysiology of respiration. So this disruption of the pulmonary ventilation, oxygenation, and respiration will cause immediate effects on the body, like hypoxia, right? So tissues of the cells of the body do not get enough oxygen. This is because they start becoming hypoxic, or the hypoxic drive then stimulates breathing when the arterial oxygen levels fall, right? That's our PaO2 levels for arterial. Less sensitive and powerful than the carbon dioxide sensor in the brainstem, typically found in end-stage COPD patients. So understand the definition of hypoxia, right? It's when the tissue cells do not get enough oxygen. Early signs of hypoxia or onset and degree of tissue damage caused by hypoxia often depend on the quality of ventilations. So our early signs would be, include restlessness, irritability, apprehension, tachycardia, and anxiety. Late signs of hypoxia include mental status changes, because now our body's not getting enough oxygen to the brain, we start becoming confused. A weak, thready pulse, and cyanosis. It's a late sign of hypoxia. We got to pick up stuff early, okay? So that tachypnea, the tachycardia, the irritability, restlessness, right? Decreasing SpO2, right? Changes in our end tidal, putting a patient on nasal cannula end tidal and seeing a tachypnic rate with low readings. Those are the patients we have to start treating before they go to a late sign. Once they hit that late sign and we start seeing mental status changes, it's very hard to control a patient at that point. Patients that have altered mental status cannot get CPAP because they can't maintain their own airway. They can't have it on because if they vomit, you aspirate them. That's back on you as a provider, right? So we have to catch this stuff in the early signs, that irritability, restlessness, apprehension, tachycardia, anxiety. Right. So again, having them be able to hold that mask to their face like this can help a lot with that anxiety and that claustrophobia that they may have. Responsive patients will report shortness of breath or what they call dyspnea, and also may not be able to talk or complete sentences. So we look at word dyspnea. How many words can you get in before you have to take the next breath? If they can speak in a full sentence like I am right now, they are not having trouble breathing. Okay. There's no word dyspnea kicking in. I could be a little short of breath, but doesn't mean that I'm critical. If you walk into the house and you see a patient tripoding, pursed lips, accessory muscle, and they're speaking 1 or 2 words for the next breath, and the breathing rates appears to be in the mid-40s, those are sick patients. Those patients are going into potential late signs and working in their way towards failure. And that's where we need to intervene. Those are your CPAP patients. Those are as you listen to lung sounds, you walk through the door and you hear audible wheezing. I'm sure some of us have heard that before, right? You hear significant bronchoconstriction. So we're going to administer supplemental oxygen before signs and symptoms of hypoxia appear. Great, we're going to administer O2. But based it on the patient's presentation, what do they need? Do they need support or just oxygen? Because support is going to be your CPAP, or oxygen is going to be oxygenation. All right. So the VQ mismatch, what they call ventilation perfusion, perfusion being the Q part. We'll look at the ratio and the mismatch that's there. So to exchange gas by simple diffusion, ventilation and perfusion must be matched. So failure to match ventilation and perfusion contributes to most abnormalities in oxygen and carbon dioxide exchange. So when ventilation is compromised, but perfusion continues, blood then passes over some of the alveolar membranes without gas exchange taking place. And a result of inadequate perfusion is less oxygen absorption in the bloodstream and then less carbon dioxide removal. Therefore, now we're retaining, right? Okay, if we can't remove it, we start taking it in, yes, right? We're retaining carbon dioxide. If we're retaining carbon dioxide, like patients that have emphysema, what starts to happen? You start seeing increase in end-tidal CO2, right? So something to think about when you're putting on end-tidal. So factors affecting ventilation. So many intrinsic and extrinsic factors cause airway obstructions. Interruptions to central and peripheral nervous systems may also have an effect on the ability to breathe efficiently. So we're talking about hypercapnia, which is what again? What is hypercapnia?
Too much CO2 in the oxygen, in the blood.
Yeah, high carbon dioxide. Right, so overall increase of carbon dioxide in the bloodstream. All right, so trauma to the head and spinal cord can also interrupt nervous control of ventilation. We just talked about that the other day, right? A patient with head trauma. So what's our magic number for end-tidal with head trauma? What's that magic number for end-tidal?
Isn't it 40?
35. Close though, right? We want to keep it that lower number because if we have a patient who is hyperventilating, the end-tidal is too low. If we're hyperventilating them, what do? We slow down respirations. If the end-tidal goes too high, we increase our respirations. It's very simple. It's just that game of trying to manage that level, right? So 12 respirations a minute may not be the key. It's whatever is based upon end-tidal CO2, right? Those are going to be our trauma patients or head trauma patients. All right. Muscular dystrophy causes degeneration of muscle fibers, slowing motor development and loss of muscle contractility. Angioedema, what is that again? What's angioedema?
When the tongue swells up really big?
Yes, so swelling of the tongue. So patients with allergic reaction might have swelling or angioedema of the tongue and experience a decrease in pulmonary ventilation, right? Because now we're not going to be able to ventilate. Pulmonary ventilation will start decreasing because of bronchoconstriction. So our bronchioles that are normally this big around start to shrink, right? They're constricting. And if they're going to constrict, we have to then fix that problem with bronchodilators. So intrinsic factors include trauma-informed body area obstruction for extrinsic, respiratory splinting, so respiratory splinting can result in a decreased pulmonary ventilation. So we're talking about hypoventilation or slow breathing. So carbon dioxide produces excess or production. Start over again. Carbon dioxide production exceeds the body's ability to eliminate it. Or carbon dioxide elimination is depressed to the extent that it no longer keeps up a normal metabolism. Okay, so slow respirations, it builds up, unable to eliminate, and then what happens? Does their end-tidal go up or down? If they're bradypneic breathing, is it going up or down? Slow respirations, more acidic,
Up.
up. Okay. Hypoventilation and hyperventilation could represent the body's attempt to compensate for various abnormal conditions. Alkalosis, high blood in the pH, high blood pH, or acidosis, low blood pH. Okay. Decreases or increases in minute volume can result in problems with carbon dioxide levels in the blood. So if our minute volume is higher or lower, it'll change those levels, which is why we have to truly base our respirations and our ventilations on carbon dioxide exchange, looking at our end tidal. That's going to help us meet that homeostasis and get to our range of the 35 to 45. Because remember, if it's too high, it's acidic, too low is alkalotic, and that changes our pH, right? And eventually you'll have some compensation with your buffer system if you can't fix that. Then our bicarb starts to change, then we start becoming metabolic acidosis or alkalosis versus just respiratory. You'll start respiratory with a compensated metabolic. Did I lose anybody on that one at all? Be honest, because this is something you guys need to know. If you have a question, ask me, please. I'm trying not to go super heavy on this stuff, but also want to make sure you have enough to be able to get through your exams and treat a patient. Right? We control it with ventilation. We control it with our minute volume. We control vasoconstriction and vasodilation based upon carbon dioxide levels in the system by controlling respiratory rate. That's why it's so important to understand end tidal with head trauma. Okay. Perfect. So other factors affecting oxygenation and respiration. So external factors will be attachment of carbon dioxide molecules to the hemoglobin. Molecules can then cause false pulse oximeter readings. Right? So patients with CO poisoning can give you false readings. This is why it's so important that you guys have RAD 57s or have the ability to monitor SPCO on your cardiac monitors. Because you may have SpO2 of 99%, but they're not oxygenating. There's just so much carbon dioxide, you have to give them 100% oxygen. Right? So what happens? So what happens if you have a patient who's unresponsive, has a SPCO reading of like 120, and they're unresponsive? What does this patient need? One word.
Oxygen.
Oxygen. Yeah, that's it. They need oxygen. And there's a specific, I'm going to call it a machine or a chamber where this patient may end up going to receive that oxygen that he needs in his system. These patients are already intubated, and usually they'll do a transfer for patients like this, but what do they actually need?
Hyperbaric chamber.
Hyperbaric, exactly. Yep. Hyperbaric chambers are not just for wound care. Okay, they can also be used for that as well, or diving emergencies too. We'll get into that in environmental. All right. So internal factors, so conditions that reduce the surface area for gas exchange, right? So we talk about pneumonia, an infection reduces that surface area. Okay. Pulmonary edema and COPD. Slide 40. All right. Hang tight about it. I want to bring something up. Let's see. Stay with me. I'm going to show you guys something. So you guys can actually see it. That is not, I did not want to put an emoji there. Ooh, those are bad. Let's see. I want to find one that looks horrible. You can actually see it. This one here is actually not that bad. We're on slide 40. Oh boy, what did I just do? I'm breaking stuff. That's because this is in the way. All right. Do you guys still see the screen or no? Is it going? We're definitely back now. All right, you guys can see that now? Okay. This is pneumonia. Okay. And what you're seeing, and then this was left border here, but if you follow my mouse here, this is the heart where it would be in here. You see that blacked out area here? Okay, that's your trachea. Those white dots you see are your spinal cord. You can see the rib cages and all that, but you see that big white mess over there? That's pneumonia. So when you reduce that surface tension, we can no longer oxygenate in that area, in that lobe, right? So this is the left side. So how many lobes do we have on the left? 2, okay? So you have upper lobe here, and it kind of branches off like this in here, and goes to the lower lobe. This person here has an upper and partial lower lobe pneumonia. There's a lot of consolidation inside of this, right? But I want you guys to see a picture of that, okay? So this is pneumonia. This is the reducing of surface tension. Therefore, because if you look really closely, and I don't know if I can do this or not, I'll probably screw something up, but do you see the white lines, and see how they get finer and finer? They keep branching out in that area there. Can you see it looking closely? It looks like a tree almost coming off. Those are the bronchi, and those are the bronchioles going into the alveolar sac. So you can kind of see the bronchi here. I'm sorry, bronchioles here in the bronchus. Breaking it down. I'm not teaching you guys how to read x-rays, but I want you to see this because it's important to know that when you reduce surface tension, this lung is not working. This side is. You can see it all through here. It's all clear, right? That's all good air. This is infection on this side, right? So that's that one there. The other one I wanted to show you guys was CHF. Okay. So I'm just gonna click on this one here for a minute. This is actually a decent one here. All right, same thing. All right, you see all that white out here and the white out here? That's fluid. They're drowning internally on this. So without getting into detail on chest x-ray reading, because there's a lot to learn when you want to learn how to read chest x-rays, this is CHF. This is very bad all through here. All right, what was the last one that was on there? All right, COPD, that's right. COPD exacerbation. Trying to find a decent one here. Let's see. So here. You see how it's kind of weighted out a little bit on both sides there? That's more of a COPD exacerbation and they can't breathe. But the thing with this is though, here with COPD, you're not going to see like the pneumonia or the CHFers, right? Now, here's another cool thing too. Here's the heart. This is the left ventricle over here. That's the right ventricle over there. This spot, you can see the trachea coming down. You see the white marks here and on this side? It goes down through here. That's the mediastinum, by the way. So you guys can actually see it in a real person. So mediastinum runs down here, and then on the other side here. And behind it's the heart and the great vessels. Right? So I kind of wanted to show you guys those. It's kind of neat. The trachea going up. Okay. Did that help illustrate a little bit better on the surface tension lost? Right. Good. All right. So other factors affecting it, obviously, is the non-functional alveoli. So atelectasis kicks in and starts shutting down. Intrapulmonary shunting, changes in respiratory rate, pain and strong emotions, a decreased metabolism, and other conditions including hypoxia, hypoglycemia, infection, okay, like pneumonia, we talked about that too, infection of the lungs, or without sufficient glucose, the cells will metabolize fatty acids, resulting in ketoacidosis. Right, we'll cover more of that in endocrine. All right. Circulatory compromise leads to inadequate perfusion. If your heart is not pumping effectively, and you have any kind of compromise, whether it be cardiogenic shock to hypovolemic shock, things like that, if patients are losing blood or the heart can no longer pump, or if you have someone with like a pericardial tamponade, pericarditis, things that can reduce oxygen levels. This leads to inadequate perfusion. Right? The blood, oh my God, the heart has to be able to pump in order to perfuse the body. And if there's something blocking it, like a pericarditis, remember Beck's triad, right? Or pericardial tamponade, like Beck's triad, or pericarditis and inflammation of the pericardium. All right, that's where we're going to have these problems. So obstruction to blood flow to individual cells and tissues related to trauma. Other conditions you may encounter is a pulmonary embolus, right? A simple or tension pneumothorax, an open pneumothorax, a hemothorax, or a hemopneumo, right? And I'll show you guys those two. They're actually pretty interesting things. Have you guys ever seen a pulmonary embolus before? Honestly, have you ever seen pictures of them or see what they actually look like? Yeah, for some reason that haven't seen it, I'll show you two of them. First one I'm going to show you. You guys see the screen okay again? Chest x-ray of this is a pneumothorax. I'll just click on this one here because it's just easier. Okay. You see that white shadowing there? Okay, you guys see that? That's the lung. It should be out here around that lining on the outside. And this is just open space. So that's a pneumothorax, almost becoming tension, right? It basically shrunk against the heart. That's a pneumothorax. To kind of see a perspective of what we're talking about. So if you have that, this is a paramedic level call. They're going to do a decompression or a hospital do a chest tube over here. That'll help reinflate the lung back to where it should be. All right. The other one is the pulmonary embolus. And I just want to show you guys what this looks like too. See if you can see better on this one here. Yeah, not the greatest. All right, let's do this then. I apologize, hit the wrong button. So these are embolisms, as you can see in these photos here. Basically, it's a clot. And one of the worst ones, and you guys can take note of this if you want, is a saddle pulmonary embolus. Okay. And what it's doing, good picture here. That's actually not bad, right? Is it comes through and here and what is this? What is this blue here? Pulmonary artery, pulmonary vein. What you have is a massive clot that sits on a saddle, the saddle here, coming from both angles, causing almost a complete obstruction. Right? That is very fatal. Here are some clots that were pulled out of someone's lungs, by the way. Okay, this is all part of a PE, what they see here. But a saddle PE, though, is one of the worst ones you can have. I've had patients with this before. They can die very quickly from that. And the picture here again, that's kind of small. All right, it just sits on the saddle between the pulmonary artery, pulmonary that sits here, and it comes up from both sides, and just kind of sits right in the middle here, going down into the right atrium. It's a massive, massive blood clot. All right. I like showing you guys some different things that are on there because you have a better understanding that's actually talking about it to actually see it. All right. Heart failure and cardiac tamponade inhibit the ability for the heart to effectively pump. Blood loss and anemia. Patients that are anemic also give you a false SpO2 reading as well. Hemorrhagic shock, vasodilatory shock, and aggressively treat any patient suspected of being in shock to prevent further interruptions of tissue perfusion. So we're going to treat them with oxygen therapy, but as an advanced EMT, you guys also need to make sure you're doing intravenous therapy and fluids, depending on what's really going on, right? If the patient's in heart failure and the blood pressure is 70/40, they need fluid in their tank. Their tank's almost empty. If the blood pressure is sitting at 200/110, they don't need more fluids at this point. They're already fluid overload. That's when they start getting into heart failure and starts backing fluid up into the lungs, which is why it's so important when we administer any kind of fluid to a patient, we're going to be checking lung sounds every 500 mLs to make sure it's not going into a space we don't want it to. Right? We just got to watch the hemorrhagic shock. All right. Acid-base balance. So I covered a lot about acid-base balance and pathophysiology. We talked a little bit about acid-base balance in the capnography lecture that I did for you. Now let's bring all this stuff together. Disruption by hypoventilation and hyperventilation. There are 4 clinical presentations. I'm going to go into this more in detail. Respiratory and metabolic acidosis and alkalosis. And you have to be able to tell the difference when looking at numbers. Okay, very, very important to know the difference. All right, this may result in rapid deterioration and death. All right, so excess acid can be expelled as carbon dioxide from the lungs, which is why patients that are breathing too slow have too much carbon dioxide. They're not off-gassing fast like they would be the patient who's hyperventilating. So slow respirations will increase the levels of carbon dioxide. So the fastest way the body can eliminate hydrogen ions is to create water and carbon dioxide. They got to start breathing. Anything that inhibits respiratory function can result in an acid retention and acidosis. Acidosis can be caused due to low respiratory rate or tidal volume. Alkalosis can be caused from a high respiratory rate or high or tidal volume. So the fluctuations in pH due to the available bicarbonate level results in a metabolic acidosis or alkalosis. Fluctuations in pH due to respiratory disorders result in a respiratory acidosis or alkalosis. Treatment for the classic hyperventilation syndrome focuses on restoring the normal respiratory rate to increase carbon dioxide levels. Now, if I said, this is where it's important, you guys have to be able to get these things down because you're going to see this stuff on an exam, especially they hit heavy on this in the National Registry. If I said you have a end-tidal CO2 of 6, this is horrible. Let's say it's 60. The pH of 7.12. What's wrong with this patient? So your end tidal is elevated, your pH is low, and this here is normal. End tidal measures respiratory, right? Is that normal, high, or low?
High. Should be
High.
respiratory
Say that again?
respiratory alkalosis.
Well, what's the pH?
No, just kidding. Acidosis.
Okay. Because the pH is going to be down as your end tidal goes up because the end tidal high is acidotic. So your pH levels are going to be kind of low. Retaining that. Got it? Okay. So let's say you have let's see. You have this. What would you call this patient? So is end tidal normal? Yes or no? End tidal normal?
Yes.
Yes,
Okay. Let's cross that out. Is the pH high or low?
high,
Which would make it
High.
alkalotic, right? High pH is alkalotic, anything higher than 7.45. Okay, is the bicarb normal?
that's also high.
Okay, so this patient would be in a take a
Metabolic,
guess.
metabolic alkalosis.
Correct. Metabolic alkalosis. So let me show you this really quick. Okay. Anything up here, end tidal, bicarb. It separates here. Okay. Anything that has to do with respiratory changes is end tidal. Anything that has to do with metabolic changes is a bicarb issue. Okay. Now, whether or not it's acidosis or alkalosis is really going to be based on the pH level. Okay. You could have a patient with an end tidal, let's say an end tidal of 18 and a pH of, let's say, 7.56. What's wrong with it? What's the patient in? End tidal of 18, respiratory or pH of 7.56.
Respiratory alkalosis.
That's it. Right there. Good job. Right. So practice these numbers. Keep going through them, right? Because you're going to see this on an exam. I know that the National Registry does test pretty heavy on acid-base balance. Write them out. There are easy ways to do this, and it's called tic-tac-toe. Right? We do that there. So if I said that the bicarb was 24, is that normal? You should be saying yes. 22 to 26 is normal range. So if I put a bicarb here, right? The patient has a end tidal of 65 with a pH of 7.1. Right? So the pH is acidic and the end tidal is acidic. So tic-tac-toe, 3 in a row, patient has respiratory acidosis. That a little bit easier? As long as you know your normal ranges and what the differences are, put them into a tic-tac-toe board. Right? That'll also help you as well. Literally memorize numbers, and you can tell the difference between the two. So I'll put these out here again. Those are going to be your normal ranges. If you don't have those memorized by the end of class, you're not going to do well on your national when it comes to acid-base balance. Having these memorized and utilizing the tic-tac-toe board that's awful. It's hard to write with this pencil on such a small screen. All right. If you know these and you know how to play tic-tac-toe, you'll be able to figure out if the patient's acidotic or alkalonic, respiratory, or metabolic. Just keep in mind, anything respiratory is end tidal, anything metabolic is your bicarb. Any questions on acid base? No? Everybody good with it for now? Clear as mud? Yeah. What I did for this, for me personally, is I would sit down and look at numbers. I would type in acid-base balance and on the computer, watch YouTube videos on it, whatever it took to get me to memorize this. And I had this stuff down pat. I can look at ABGs and tell you how to fix a patient with a vent now. Of that and going through school. But this is the basics. This is the base knowledge of how to fix this. And we have patients that are in respiratory issues quite often, and we have to be able to fix that. So if I put a patient on end tidal and I see a reading of 66, I know that I have to then do what? I have to start ventilating them, right? Appropriately. Take a look at what you have here. Know your numbers, okay? Know your end tidal numbers, right? Know your end tidal CO2, bicarb, pH. Look at your tic-tac-toe board, put things into it. It'll help you get through your tests. Seeing it for real on real patients will definitely make a difference. Your head trauma patients, you have to maintain an end tidal of 35, right? We want to make sure we're keeping that homeostasis. We don't want vasoconstriction, vasodilation based on carbon dioxide. We got to fix it, right? So me as a medic, if I'm in the back of the ambulance, once I get area established, if I intubate a patient, whatever, and say, here you go, this is going to be you, you're going to ventilate the patient, watch that number, right? I'm going to do other skills, procedures that have to be done, right? And that's what you're going to look for. You're going to look for that number. If you're in the back with a flight crew doing anything with critical care medicine, the same thing, right? If life flight comes in and intercepts with you, they're going to tell you to do the same thing if you're bagging a patient. They're going to say, watch that number for head trauma. If our side, they've intubated, this is what they have. And you got to watch those numbers. That's going to be very important. So know these numbers inside and out. Right? That'll be good for you. It's good material to understand. All right. So, airway evaluation. Recognizing adequate breathing, otherwise known as eupneic breathing. Breathing would then appear to easy, not labored. Our normal respiration for the adult is 12 to 20, right? 15 to 30 for child, 25 to 50 for pediatric are normal ranges. We're looking for adequate depth and tidal volume, right? Adequate depth and tidal volume. If there's changes, that changes our breathing statement. Regular pattern of inhalation, exhalation, breath in, breath out. Clear and equal bilateral breath sounds. You're checking 8 spots in the back, 4 spots in the front, right? Get a good set of lung sounds. Everything is moving in and out of the lobes. Now, distress may be a result of upper or lower airway obstruction. So an adult patient who is breathing at a rate fewer than 12 or more than 20 should be evaluated for other signs of inadequate breathing. Remember that sepsis indicators as part of your systemic inflammatory response is a respiratory rate of greater than 22. Okay, that's one of the indicators. Patients with respiratory distress often compensate with peripheral positioning. Positioning. Respiratory distress may be the result of an upper or lower airway obstruction. Okay. Inadequate ventilation, impairment of the respiratory muscles, impairment of the nervous system. Dyspnea is difficulty in respiratory rate, regularity, and effort. May result in hypoxemia, right? So hypoxemia, breaking that down, is oxygen in the blood. May also, untreated hypoxia result in anoxia and death of the body's cells and tissue, which is why we need to make sure that patients are oxygenating, but they also have to be perfusing. So we need to make sure, once again, that we're monitoring end-tidal CO2 and pulse oximetry. Right? We got to be able to see both of those. That shows us our perfusion status and how we are doing. Right? Determine when assessing a patient with respiratory distress. We need to make sure that we're observing, we're palpating, and auscultating. Right? Is it a fractured rib? Is it flail segment causing that distress? Right? Do they have equal rise and fall? Do they have increased AP diameter of the chest, what they call barrel chest? If they have barrel chest, that indicates the patient has emphysema, right? So the things to look for, especially if the patient's altered, and I see a barrel chest on them. Okay, well, are they hypoxic because they have emphysema? Can we treat this? Yeah, we can start giving some bronchodilators, opening things up again, and hopefully in turn, reduce that hypoxia and start oxygenating the system. Is the patient experiencing positional dyspnea? Orthopnea, right? Positional dyspnea. Patients that weigh 400 pounds laying flat on their back. Can they breathe? Maybe not. They may struggle. If they're leaning on their side, crushing their lungs, they may struggle to breathe. Patients that are prone, especially large people, right? Their chest walls, they can't increase and decrease their chest walls, all that weight is sitting on top of it. Otherwise known as positional asphyxia, right? So we got to look for that. How many times have you guys gone to the nursing home before as EMS providers, and they got the patient on a non-rebreather at 2 liters a minute, and they're laying flat? And you sit the patient up, you take off that non-rebreather and put them on a nasal cannula at 4 liters a minute. It's amazing. They feel so much better, right? We've seen those calls before. Patients that have difficulty breathing, we need to sit them up. Let their lungs work less. If there's fluids, they're going to go back to the bottom instead of distributing throughout the entire of the lungs. In pneumonia patient, they feel better sitting up, right? So we got to do that, right? Is the patient gasping for air? right? If they're gasping for air, this is a very, very bad sign. These patients need CPAP, they need BiPAP, they might need to be RSI and intubated, right? That's going to be up to you guys' determination based upon your assessment. What do they need at this point in time? Is putting the patient, if they're not altered, they're alert oriented but gasping for air, can we put them on a CPAP and start inlining nebs, again, depending on what's going on, or do they need nitrates and things like that for an active pulmonary edema? What color is the skin? Is the skin moist and clammy? If the skin's moist and clammy, they're in shock. The body's trying to compensate, and they're in shock right now. They have an inadequate state of tissue perfusion. They're not getting adequate breathing, right? And the skin is blue all around and look like a Smurf. That's bad. That's significant cyanosis, right? So we got to look for those different signs and kind of see what level they're at this point in time in that difficulty breathing phase. So recognizing that inadequate breathing. If there's flaring of the nares present, is the patient breathing through pursed lips, creating more PEEP? Our vocal cords create PEEP. If a patient is intubated, they no longer can make PEEP anymore because the vocal cords have been taken away by an intubation tube, which is a straight shot. We need vocal cords to create PEEP for us to be able to breathe on a normal basis. And other than that, it's very difficult. If it's worse, they start pursed lip breathing. If you guys want to try it, you can see it. You deep breath in, breath out with your mouth wide open, and then deep breath in, breath out with your pursed lips if you're trying to kiss something, and you'll see the difference. It's allowing for that exchange to be a little bit better, right? To allow for those lungs to open a little bit longer. Do you know any kind of retraction, skin pulling around the ribs during inspiration, intercostal changes at the suprasternal notch, at the supraclavicular fossa, and the subcostal? So you're looking at different ranges on the chest. I'll show you guys some stuff here in the next slide. Is the patient using accessory muscles to breathe? Is the patient's chest wall moving symmetrically? Are they going up and down at the same time, right? Is the patient taking a series of quick breaths followed by a prolonged exhalation phase? Right, here's your sternocleidomastoid muscle, right, up here. Major muscle on the neck, runs down there to there. This is your pectoralis major, your chest walls muscles, and your rectus abdominis muscles down here. So we looked at labor breathing. Patient with inadequate breathing may appear to be working harder to breathe. We have to be able to pick up on these different clinical signs, right? If a patient with significant shortness of breath has their shirt on, are we going to see any of this? No. And people may think I'm foolish at times, but I carry hospital gowns in the ambulance. Well, I was up north. I don't carry them down here, but when I was on the truck, I always made sure we had hospital gowns because the patient's shirts would come off, bra would stay intact to keep female dignity. I get it. It gives me an open spot to do 12 leads. It allows me to completely observe my patient. I don't have to move things around to get lung sounds. And when I'm done with all that, I put them on a hospital gown. That way there, if I have to reassess the patient, I can easily lift it up. It's not going to be tucked in. It's not going to be in the way. There's nothing wrong with changing your patient in the ambulance. Just make sure you're doing it with dignity, okay? And keeping the patient's dignity as intact. Right? But you have to be able to assess. And if you guys are doing assessments and not lifting up the shirt to look at certain things, right? We're missing stuff, right? We don't want to miss the assessment. Take a look. All right. So recognizing inadequate breathing, signs of inadequate breathing in adults are a respiratory rate fewer or greater than 20, irregular rhythm, diminished, absent, or noisy auscultated breath sounds, abnormal abdominal breathing, reduced flow of expired air at the nose and mouth, and unequal or inadequate chest expansion. And we can monitor this stuff here real time with end time. Right? Other than listening to lung sounds. That has to be part of you listening. Increased effort of breathing, shallow depth, skin that is pale, cyanotic, cool, mottled, or moist or clammy, retractions, right? Different speech patterns. Pay particular attention to the external environment. Okay, auscultate breathing. Listen to lung sounds, right? Feel air for air movement in the mouth and nose. If you have to, if they're unresponsive, put your hand close to the face. See if you can feel it. Observe the chest for symmetry and note any paradoxal motion. Are they doing this? Or are they doing this? Evaluate for pulsus paradoxus, as well as assess for history and the present illness. What else has been going on? Note protective reflexes of the airway and modified forms of respiration, such as a sighing or hiccuping. Serious head injuries may also cause irregular, ineffective respirations that may or may not have an identifiable pattern.
I found some web results. I can show them if you ask again from your iPhone.
Really? All right. This is what they call ataxic respirations. Right. What we're looking at here is the Shane Stokes breathing. So you see inspiration and expiration here. So you may see this type of breathing pattern. Others look for is agonal gasps. So be vigilant when monitoring patients in respiratory distress. Right. So if you've got a patient who is not doing well, they're on end-tidal CO2 monitoring, and you're trying to work for a line, you're doing something else, you're distracted with the monitor, trying to get a 12 lead, and the patient stops breathing. Right? Unless you look back up at that patient to see the agonal gasps or that change in status, you may not pick up on it. But when you have a patient end-tidal, it's almost immediate. An aptic alarm starts sounding after 30 seconds, but you'll see the waveform stop. Right? So look for those agonal gasps. You can see the respiratory status on end-tidal readings. So again, like I said before, tell me a reason when not to use it. Okay? But we use it on almost every patient that's sick. All right. Let's see. We'll go for about 10 more minutes to take another break. So assessment of respiration. A patient's level of consciousness and skin color are excellent indicators of respiration. Right? If they're alert oriented and their skin is pink, warm, and dry, we know that they're perfusing. We know that the respiratory rate is working for them. They're getting good respiration. When trending patients in altered mental status, always consider the possibility that the patient may not be getting adequate oxygen to the brain. I keep bringing up end-tidal. We're going to monitor these patients. To determine a baseline mental status of the patient, consider proper oxygenation when assessing the patient and utilizing pulse oximetry, non-invasive method of measuring how well the person's hemoglobin is saturated. But again, a tool is only as good as what it can provide you. Anemic patients, carbon monoxide patients, those patients are not going to have decent, or that's why they're going to have a decent SpO2, but in all reality, they're not oxygenating very well at all. All right. So keep that stuff in mind. Work with things hand in hand. Use them both. So this is a pulse oximeter for those who don't know what one is. So to ensure that this works appropriately, it's a good instrument in measuring arterial and not venous oxygen saturation, called SpO2. Pulse oximeters are designed to assess only pulsating blood vessels. Right? You can check by comparing the pulse readings with the measurement obtaining by palpation. Right? Things that can produce erroneous readings. Well, you guys all know what pulse oxes are. Bright ambient light. Pulse oxes do not like light. Right? So the infrared inside of here, if light hits it, you're going to start getting false readings. So always put a blanket over the patient's hand or something. Right? I know we always do it out in the open. Try to cover the hand, you get better readings. Okay. Patient motion and movement. Right? Poor perfusion, so the hands are really cold. You don't get very good readings. A lot of times they also make ear probes. Those work really well. Nail polish. I found in a quick way before nail polish remover is used on a patient, which you should be using, just turn it sideways so it sits sideways on the finger like this instead of like this. You get some readings. venous pulsations, abnormal hemoglobin. Do not make treatment decisions based solely on pulse oximetry. It's not always accurate. Remember that if you have a Zoll monitor, you can also change your sensitivity levels in those by highlighting the SpO2, going down to sensitivity and changing it to maximum, and that'll give you a better reading. But what we're really looking for, and it's not really discussed in this at all, is the pleth. When it comes up, comes down, like that. Okay, that's good pleth. If you see this, which we've all seen before, right? That's not good pleth. We see this, we're not getting an accurate reading. Right? This should be your heartbeat. This should be following your systolic, diastolic, systolic, diastolic. This is your heart beating going through there. Okay, that's what you should be seeing on a cardiac monitor, which you guys will be using as advanced EMTs anyways. So put the patient on the monitor, look for that pleth. If the pleth isn't there, move things around. Right? That's how you get accurate readings. But working in conjunction is end tidal. We're going to cover that here in a second. Not as in depth as we covered on last class. Peak expiratory flow measurement helps evaluate bronchoconstriction. Increasing peak expiratory flow suggests the patient is responding to treatments. We do not do this in the back of the ambulance unless you guys have them in your trucks. I've been on an ambulance unless it's interfacility doing long distance respiratory transports. I haven't seen these peak flow meters at all. Have I used them in the ER? Absolutely. I gave them out to patients all the time there. Right? We had to check them really quick, document the numbers, and then set it where the numbers should be on here with a little red dial. And that was their goal to hit that point. Decreasing peak expiratory flow may be an indication of deterioration. This varies on the sex, height, and age of the patient. And perform the test 3 times and take the best peak flow of the 3 readings that you get. Right? That's how that works there. I don't know of any service, if you guys carry them, let me know, but I don't know of any service that actually carries peak flow meters at all. But if you have them, it's done with three different blows in to see what you can get for a peak movement. All right. Arterial blood gas analysis. All right. I don't have everything here in front of me. As far as, let me just go over the slide really quick, and then I'll cover more in depth, or more later. Provides the most comprehensive quantitative information about the respiratory system, right? A normal ABG values are summarized in table 11-16. Do you guys have them in your books, okay? In your ebooks. Take a look at them. I'm not going to hit these heavy with you guys, because really it's just more numbers you need to be somewhat familiar with, but to maintain normal ABG values, the balance between alveolar volume and perfusion of the alveolar capillaries must be maintained. End-tidal carbon dioxide assessment detects the presence of carbon dioxide in exhaled air. Right? Types of monitors include colorimetric, digital, and digital waveform. These are your yay for yellow ones, right? The ones that are start purple and turn yellow if you have a good intubation. Digital just shows you the number only. Our cardiac monitors are digital waveform. This is the best one to be utilizing right here. Why? Because you can see your numbers, and I can see my waveform. Right? That's what's very important with those. As far as ABGs, we don't do them in the ambulance. Hospitals do them. Literally, it's sticking a needle into the radial artery straight in. They draw up some arterial blood. They send it to the lab and get gases back. You'll get your pH. You'll get your carbon dioxide. You'll get your PaO2 levels. All those different levels you're going to see. But we're not going to see those in the back of the ambulance. Another one they can do too is called a VBG. It's full of venous blood gas. That can be pulled off a blood tube and sent to the lab. Right? The only thing you're not going to get is a PaO2 level in it. Not a big deal. Okay. Enough on ABGs. We don't really cover much of those in this level. This right here is a colorimetric. Okay, that's usually purple to start. Once you start ventilating, it takes about 4 or 5 squeezes. And this will turn yellow in here, hopefully. The capnometer provides quantitative information. All right, this is your end-tidal CO2 number here. This is your respiration is down here. Right. I haven't seen many of these around because we have the ability to use them in our cardiac monitors. Now, here are some potential false readings for these. Okay. You might get a false reading that the patient has carbon dioxide trapped in the stomach from ingestion of carbonated beverages. I've also seen false readings before on patients that had a high overdose of antacids. Okay, and that's only because they put an intubation tube down the stomach and they were getting some readings off of that. Other than that, there's really not a lot of error. They're less reliable if vomitus or secretions get inside of it. Remember, it's pulling that gas through the tube, right? So I don't see any more on here coming up in the slides. That's why I mentioned before, if you guys have them, turn them so the tube is aiming up, the line going into the monitor, and leave the T piece down low, or the connector, the 1522 adapter connector down low. That way there, if there's any condensation that builds up over a long-term transport, it sits on the bottom, won't get into your capno line, and you won't get false readings. If it's covered in blood and vomit, you got to change them out. I always carried 2 on my cardiac monitor, and I always carried an additional 2 in my intubation bag, only because you might go to 2 or 3 of them depending on the amount of vomit that comes out. So same thing, you guys are putting in supraglottic airways. You know, if you're in New Hampshire, you're already putting them in now as EMT, and you guys are using waveform capnography to confirm. So it definitely helps. All right. All right, next slide. Here we go. So a capnographer is a device that provides a graphic representation of exhaled carbon dioxide. I'm not going to get in depth on this. We covered it last class. Okay. But again, exhalation up, plateaus off. This is your end-tidal number. Inhalation. That's 1 cycle, 1 breath. Right. Remember that this narrows in hyperventilation and it widens in hypoventilation. Right. This will drop in hyperventilation. It will rise higher than 45 in hypoventilation. These are quantitative waveform capnography devices. This is the nasal cannula. This is the what they call mainstream, or the one that we utilize for intubation tubes, BVMs, supraglottic airways, etc. This is the capno line I was talking about coming off. So you want this part here, if the patient is flat, aiming up. That way their condensation can build down here and not block that line. Once you start sucking stuff into this line here, it clogs it up. Throw the line away and put a new one on at that point. Okay. This serves as an indicator for effectiveness of chest compressions and ROSC. Right. You're going to see ROSC about 2 minutes with increased end tidal before you start getting pulses back. So something to think about as well. All right. We covered that a lot last class though. All right. 8 o'clock. Let's take 10 minutes. Come back at 8:10. And we'll finish up. Anybody back yet? Hi, Mike. I want to know if you can. Oh, I just broke something. Hold on. Can you see the video that's on there?
Yes.
I'm going to play it because I don't know if you can hear it. I'm trying something different. Can you hear the video?
I don't hear it.
Nothing at all?
No.
Well, that's. Oh, no, I hit that button. Let's try this. What now?
Okay, so bagging without
Yeah.
peep.
Yeah, I can hear it.
Overlaps, so we're not really recruiting hardly any alveoli.
Cool. All right. I didn't mean to take you away from your break.
It's all right.
Then we'll go back to the slideshow after. I really want to explain to people what PEEP is like. It's important to know. What if I can get some pig lungs? Let this one give me some. So like a Laura, I'll show you guys. Let you play with pig lungs. How's class going for you so far?
It's going. I mean, it's the quiz.
Have I lost you yet with anything?
No. It's like medic school is coming right back.
I'm sorry. I'm trying not to like over explain certain things, but it's tough to hold back so I don't lose anybody. But we're getting there. Acid-base balance is so important. We think about like, oh, we don't do a lot of that in the ambulance. Well, we really do. We do quite a bit, more than people even realize.
Oh yeah.
Especially on the respiratory side of things. Like what we can truly change in someone with a respiratory distress.
Right.
I think it's phenomenal that we're giving EMTs a higher scope to be able to treat respiratory now.
Right. That's very interesting.
It is like Zach and I were talking. They talked about ABGs in here. You didn't learn that in medic school. If you did,
Right.
you barely touched on it. You know, and that's why we don't cover it in depth because I'm not going to test you guys on ABG numbers.
Right.
But you're going to see some stuff. So, like I was telling people before, I mean, you're going to see pH, bicarb, and end tidal readings on your national registry. You will see it.
Yeah.
Yep. That got a lot of people the first time through, not with me, not my classes, but because I knew what to expect. Because people told me, hey, by the way, there's end tidal questions on there. Or acid-base balance questions. So I started doing the tic-tac-toe version of acid-base balance. And I was teaching them that. They brought it to the test with them. They went in there and on a piece of paper, they did a tic-tac-toe board right off of that. And they got all and then they passed. So I said it was very helpful.
Yeah. I got a lot of questions on the medic test with the acid-base balances and stuff like that.
Right. It's definitely a lot. It is. So I apologize for canceling class last night. You guys get the email for that?
Yeah, I got the email for that.
They actually went through. That's good. So I was going to do trauma triage last night. We moved it to next Wednesday. If anybody wants, it's Con Ed, so I mean it's not required for our class, but if anybody wants to attend it, that's fine with me. You know, and if you want, I'll give you certificates anyways, but you guys are all going to pass your class anyways. Let's see. See if I can yell that. Well, they actually ordered it. That's surprising. No, never mind. That was a previous order. We just ordered 5 SPO2 cables.
Oh,
No,
wow.
6. Sorry, $2,200.
Oh,
$2,200. Insane.
yeah,
What do you got? A couple more minutes left before we get started here.
yeah.
Oh. Hi, Austin. How are you?
Good. How are you?
Pretty good. I'm glad everything's going well. I see Jen and Owen are still here, so they haven't had any calls yet. But if you get one, make sure they put end title. See, Cannon's back. Sean's probably back here in a minute. Owen, you back?
Yes, I am.
I just can't see you. It's very disappointing.
And he's such a handsome fella, too.
Gotta get that camera fixed. So what I'm going to do is show you guys a video of visualizing PEEP. It makes a lot more sense when you see it. And if I could find a way to get some pig lungs, I will, unless you guys know of a pig farm somewhere that wants to donate some lungs to you and bring them into class, we can definitely do that. All right. What they'll do is they'll put it in, what I'll have Laurel do is put an intubation tube in. You guys can ventilate pig lungs. It's pretty neat. I went to an advanced airway lab up in northern Maine somewhere. It was Dr. Peter Goff, one of the best airway guys I ever met in my life.
I love that guy.
He knows him. All right. I went to his airway lab and you see his sheep farm, whatever it was. He has like 300 sheep or goats or something on his farm there. And they sedate them and they kill them off. And we get to play, we get to intubate him and everything else and whatnot. And then at the end of it, he sells the meat or gives the meat to charity or something.
He still teaches it at the Samoset.
Yes, we went to his house to do this, and he had a class. He had 2 different classrooms on his property. One of them had 17 different airway heads that he manipulated for advanced airway, and then he had another classroom which was all lungs and everything, real goat lungs. And then he invited us to his house, and there's a restaurant in his home. Unbelievable. It was $300 to go for a 1-day class. But let me tell you, the amount of stuff we learned on airway management. And I was younger too. I was still an intermediate. I wasn't even a medic yet. But we could still intubate back then as intermediates and in Maine. So yeah, I'm going back to 2007. So I'm not sure if anybody was practicing medicine back then in this class. But it was just what an amazing time. And he's just such a phenomenal airway manager as a physician. It's just unbelievable. So a lot of credit goes out to him. So if you ever get a chance, you see Peter Goff for Airway Lab, you guys get the opportunity to take it at the Samoset or whatever, take it. Because he will teach you guys some stuff you never even heard before. He's awesome. He's phenomenal. All right. So let's get started back up. I'm bringing this video up here. We just did a trial really quick with Mike to make sure you guys could actually hear it. I'm hoping it actually works. But this is visualizing positive and expiratory pressure. And this is what CPAP does to a patient. But on top of that, your BVMs. So you see my mouse right now moving? Right here, you can apply a PEEP valve. In New Hampshire, that is required in every ambulance. You have to have a PEEP valve accessible BVM. We have these in every truck. an action ambulance, and it has to be able to have the PEEP valve to be administered, or we have the ones that are built in. But it has to have the ability to be able to get PEEP now, which is phenomenal. And here's a little video on how PEEP works.
Okay, so bagging without PEEP.
Yes. You see how the lung collapsed? So we're not really recruiting hardly any alveoli. Air's going in and going out.
Okay.
Look how fast he's squeezing that bag. All right, now we're going to add PEEP to this. Okay, PEEP supplied.
Keep an eye on the lungs.
Now you can absolutely see the alveoli being recruited by the hundreds of thousands, which is why the lungs are staying.
So they stay inflated
Nice
much
airway.
longer. And you can't overventilate this patient?
You can, you certainly can. So you adjust your PEEP anywhere from 5 to 20. 20 is the max that it would do, and you just watch the patient. You're driving for an O2 sat of around 94. Doesn't even need to be at 100%. And you adjust your PEEP accordingly. The only way you can increase the FiO2 when they're already on 100% O2, the only way to increase that number is through PEEP. Like by breathing faster. That's going to cause more intrathoracic pressure, decreasing the cardiac output, decreasing the SpO2, causing you to bag faster, and then you just get into this vicious cycle of bagging death.
What's your current PEEP setting?
So our current PEEP setting on this one right now is 20 millimeters of mercury. We can back it back down. Okay, this is 10. Go ahead and grab 'em. So this is 10 of PEEP. Still, you can see it's recruiting out of villi. This is 15. This is 5 of PEEP right here. So you can see that's our physiologic norm. That's almost like not having the PEEP valve on at all. So that's 5. You can just cruise this up to 10. And now we'll get more functional reserve volume. We got more tidal volume now going on. We're recruiting tens of thousands of alveoli. There's 15. We're starting to just get into that bagging nose, and then there's 20. And you can see the difference when flight crews bring people, when we put people on our ventilator on PEEP, and then if you go to ventilate the patient with the BVM, you don't have a PEEP valve on, watch what happens to your lungs. So let's say the crew doesn't know what they're doing, or the ventilator's alarming, or worse, you get him in the hospital, RT's there bagging him. Watch what happens to my lungs when I take away that PEEP, and you just go straight BVM. Look what happens. We lose all our pressure.
Oh, yeah,
So-
like you were like in the negative.
Yes, so it clinically doesn't make sense for anybody on a ventilator of 6 to 10 to 20 of PEEP. Like, oh, I don't know what's going on, the ventilator's alarming, pulling them off and BVing them without the PEEP valve on. They clinically cannot get better. People squeeze faster, but that's horrible for patients.
So you got a patient and you're BVMing them and their sats are 80 and their sats are 80 and their sats are 80. You throw that PEEP valve on, you keep that O2 in their lungs longer.
Look,
And you recruit those
you're recruiting
alveoli.
alveoli. What's the hardest part about blowing up a balloon?
The fact that it's pushing back against you.
The initial, once you get that balloon going, it's easier to blow up. So that's what your PEEP is really doing.
Cool.
It's distinguish
There's already a
alveoli.
pressure there,
Yeah.
and then when you try to inflate it,
PEEP.
it's that much easier.
Yep.
Use it.
Use it.
I meant mistakenly.
Yeah.
Right.
Hi, I'm Mark from ACLS Certification Institute, and in today's video presentation, we're going to talk about end-tidal
We're
capnography.
not going to talk about that anymore. All right. So what do you think? Yeah. This is why, and he reiterated what I was saying before. This is why we do not start with a PEEP of 20. We start at 5, we work our way up. Our norm is 5, and we go until we start seeing results. We can over PEEP somebody. It can cause significant damage, applying a lot of trauma to the chest and to the lungs. So we want to make sure that when we're giving somebody PEEP, start at 5, go to 10, go to 12, 15, work our way up till we start seeing the results we're looking for, right? That's how we're going to work that. All right. Any questions on PEEP? No? Good? All right. Love it. All right. So a lot of BLS stuff here, opening the airway. We open the airway because the tongue is blocking the air passage, as you can see down here. So we do a head tilt chin lift, or we can use a modified jaw thrust maneuver to open that up to allow for air passage to work going down into the lungs. All right. This is a head tilt chin lift. I'm not going to go over this, and you guys should know how to do this already. This is a jaw thrust. Right? This is a tongue jaw lift maneuver. This may be beneficial for you when you're applying supraglottic airways. Okay? So to be able to displace that jaw and that tongue, to be able to apply in an eye gel or a king tube. Definitely helps. Right? This is when you put a patient in left lateral to protect the air. This is called the recovery position. You guys have heard of that before. All right. We're going to quite fly through the rest of these here now. This is suctioning. Remember, no more than 10 to 15 seconds and a circular motion on the way out only. Right? Because you will be tested on suctioning skills at a random BLS station. Right? If you hear gurgling, suction the patient's airway. Right? Suctioning is very important. Even if there's just saliva in the airway, get it out. Okay? If you're calling for an ALS intercept, because you need intubation, get the suction out. I use it every single time I intubate. Most every time I intubate, I will have suction out, or either that, or I'm using something called like a salad technique to utilize for continuous suctioning for intubation. But if you have secretions in the airway and you need to secure an airway, and you're calling for a paramedic to come on board, make sure the suction's ready to go. It should already be out anyways, and you should be suctioning. The one you see over here, this is a handheld one. Does not require batteries. You are the battery. These are your house suction units here that are in the ambulance. Right? Provides vacuum pressure and allows to suction the mouth and oropharynx. There we go. This is a portable suction. Right, 300 psi for 30 seconds is the normal test you guys will utilize when you do your checks in the morning. Other than that, make sure that the battery is good, it's plugged in. And one thing I noticed about these ones here is the batteries die very fast if they are on the charger for long periods of time. So just keep an eye on the battery life on those and just test them. Right, this is a suction catheter. Right, and this is a hollow cylindrical device used to remove fluids and secretions from the airway. All right, this is called a tonsil tip, otherwise known as the Yankhauers. Right, hard tip suction. There's all different names for it. All right, great for suctioning. Just make sure you have some sterile water next to some waters you can suction it afterwards if you have a lot of secretions. Right, these are your French tip or whistle tip catheters, or what they call non-rigid or soft plastic. They come in different French sizes that you can utilize. The smaller the number, the bigger the opening inside the tube. Okay. These work great for suctioning trachs. If you're doing deep suctioning, they work really well. They also work well for like noses, things like that. Pediatrics, I mean, I've used the end of these here and shoved it in a kid's nose before and suctioned out if I had to. But I use more of these for intubation tubes and things like that. Never insert a catheter past the base of the tongue. Right, and always make sure you always measure. Right, numbers to keep in mind: 5 seconds for infants, 10 for children, 15 for adults. Right, turn on the suction and test it. This is at 300. Right, so crimp the line and test it for 30 seconds. Make sure it's working appropriately. And you can adjust the dials and make sure you're not over suctioning. You want to keep it in that green zone. All right, any questions on what we covered already with this stuff? You guys feel comfortable with it? If you don't, please speak up. I can only see Austin's screen right now. So, all right, next one. Tracheobronchial suctioning down the ET tube. All right, what we do is we take this, we shove it down the tube, and we only suction on the way out. And this is how we right here, how we control the suction. Right. Pre-oxygenation is essential when you're doing a lot of suctioning because it does suction the oxygen out of the lungs. So something to think about. In no more than 15 seconds. All right, oropharyngeal airways, these are called OPAs. You measure them from the corner of the jaw to where? So here to here, right? Here to here for NPAs. OPAs are from the jaw to the corner of the mouth, right? This is the flange up here. This will sit on the top of the lips. Remember, they go in, hit the soft palate and turn and drop it the rest of the way in. That's the way I teach it. There's other methods you can utilize too. This is called an NPA, right? Please make sure that you apply a lubricant to it so it goes in easily. Please do not use your own spit as a lubricant. I've seen people do that before, and that's disgusting. And very, just don't do it. All right. If patients have a gag reflex, we should be using these ones here. Please do not use the OPAs if the patient has a gag reflex. All right. That's right. Keep this in mind. It causes and triggers vomiting. It causes more mess for us. Right. Contraindications, severe head injury with blood draining from the nose. Right. Basilar skull fracture, contraindication. History of fractured nasal bone. If you meet resistance, do not shove it in harder. Stop. All right. Please do not shove these things in with force. They should be able to slide right in. The big thing to take home from all this, as a remember, the bevel side goes towards the septum of the nose. All right, moving forward. This is oxygen, in case you didn't know what it was. Administered to a patient that has potential hypoxia. If they are short of breath, give them oxygen. Right? But please, if they are short of breath and they're satting around 92%, they don't need a non breather. Work with a nasal cannula. Put in an internal nasal cannula, see what how you're perfusing. If it's not going up, they start becoming more hypoxic, then we can switch over. But keep the nasal cannula antenna running, or I should say running, the antenna part of it, and put the non-breather over that. Okay, so you can still monitor it. And yes, you can also monitor end-tidal through your CPAP as well with the nasal cannula. Just put the CPAP over the nasal cannula. Right. One time you got to be careful is when the patient has like massive beards. Sometimes you don't really get a great seal, but CPAP has to have a good seal for it to truly work. All right. Cylinders, make sure that you check them, make sure that the month and year stamps are on them as well. Check the labels, make sure it's actually oxygen, not just nitrous oxide. That'd be a fun night. Huh. All right, what else we got going on here? Liquid oxygen, oxygen that is cooled to an aqueous state, larger volume of oxygen can be stored. I'm not seeing many 911 ambulances with this, but like your children's trucks, I've seen them on the systems now. A lot of your CCT trucks are getting these because they can have more oxygen. They also have medical air as well. Safety considerations, obviously, to ensure correct pressure regulator is firmly attached before transport. And then puncture or hole in the tank and cause the cylinder to become deadly missiles. Please use caution with oxygen tanks. They're under a lot of pressure. All right, this is your pin stuff here. So a pin indexing system prevents oxygen regulators from being connected to a different cylinder gas, every gas cylinder. So they are different. Medical air is different than oxygen. Right? We don't do a lot with medical air in the 911 system. That's more for neonatal transport. They use a lot with isolettes in pediatrics where they don't need oxygen, they just need air. So again, we're not going to deal a lot with this kind of stuff. But as far as oxygen goes, they want to make sure it's the right cylinder, so everything has the right thread count. And safety system for large cylinders known as the American Standard System. Each cylinder has a specific gas is given a pattern of number of pins. All right, pressure regulators reduce pressure to a useful range. The two-stage regulators will reduce pressure first to 700, PSI, then 40 to 70. Right, I'm going to show you guys that hopefully in the next slide here. Final attachment for delivery would be the quick connect female fitting and a flow meter. So let me go to the next slide. I'll show you this here. Right, this flows from 0. Oh boy, there we go. From 0 to 15 liters, right? There is a way on here to flush these. If you open it all the way, it goes to like 50 PSI. You just don't see it, right? So you can open these all the way that it flushes it, but this is not where you hook up. Again, if you have a medic with you with a ventilator, these come off and hook directly into here. The vent stuff, they should be hooking into these. Now, you also have some that have dual regulators on them as well to kind of see those different. This is called the Bourbon gauge flow meter here. This is the pressure compensated flow gauge. All right. So open the flow meter to desired flow rate, confirm the flow rate on the device, apply the oxygen device to the patient, and make any necessary adjustments. Right. I'm kind of just reviewing this stuff with you guys. Again, it's all review. So please do not put it on the patient's face and then turn it on. I've seen people hit the oxygen thing before, and somehow when they were like draining the tank and they left it on, opened up all the way, and they get like this massive flush of oxygen in their nose. This is uncomfortable. So make sure you turn it on first, set your flow, then put it on the patient. Right. As far as hazards and the supplemental oxygen, obviously oxygen toxicity. Remember I mentioned before, our normal ranges are 99, 94. Right? This is the normal range we gotta look for. Nothing above 99. Once it gets to 100, it can keep climbing. And the only way to truly see what the actual number is through an ABG. Right? You can have oxygen toxicity. Oxygen toxicity and extra oxygen starts giving off free radicals and it goes into the system. Okay, so that's what we want to avoid. It's actually very deadly. It actually can hurt the tissue and the cells. Right, so you can over oxygenate a patient. Tailor the oxygen therapy to the patient's needs. What do they need, right, for that? Right, if they're standing at 94%, put them on nasal cannula 2 minutes if they need to go up a little bit higher, if they're short of breath. Right, if they're standing at 60%, then we need a non-rebreather, maybe CPAP. It depends again on your clinical presentation. Right, you can deliver them through a non-rebreathing mask, BVM, nasal cannula. 22, 44%, 100%, 90%. Those are your oxygen levels based on percentage. Know those numbers. Okay. Nasal cannulas, 1 to 6 liters. Right, BVM. I don't want people to put these at 25 liters per minute. A lot of times 15 is fine. As long as you fill that bag reservoir, you're good. Non-rebreathers, okay. Depending on what book you read, you can do 10 to 15. If the patient's on 10 liters a minute and they're sucking down the reservoir bag, then increase it up. Right, I've seen patients put them on 15 liters and the bag doesn't even move. So you can actually decrease that a little bit. Right, don't waste all your oxygen. The non-rebreather mask is the preferred device in pre-hospital setting, but contraindications if the patient's apneic or poor respiratory effort, that's when we have to go to the BVM. All right. This is a non-rebreather mask. Please make sure that you hold and fill the reservoir bag. I have popped these before because I wasn't paying attention to the back of the ambulance filling them before, and then they explode. Well, I said that they put a hole in them, make a loud pop. So again, make sure that you fill the bag, put it on the patient's face. This is the nasal cannula. The one thing I hate the most is people put these in upside down. These curve for a reason like this. So it follows the curvature of the nose and the nasal passages. So when you put it on upside down, it really doesn't get the good effect. Remember that patients with COPD at home may have home O2. This is a partial rebreathing mask. We don't really have these. I don't, do you guys carry these at all? Okay. I don't know many services that do, that carry partial rebreathers anymore. Venturi masks. When CPAP first came out, the Oxy PEEP, there's another one that was out there. It had a Venturi type system in it to create PEEP. I haven't seen that in a long time. It was back when CPAP first came out in Maine. That was many, many years ago. All right. This is the trach mask right here. So they make special ones that fit over this. Now, if you don't have one available and if your service doesn't carry them, take a non-rebreather and put it over the top and fill the reservoir bag. And that will work. All right, but they do make special trach ones that go over it. They have a strap that goes around the neck. This one here, true, looks like a non-rebreather. I don't know why they didn't actually put a trach mask on there. This is where the nose pinches off. So they didn't do a good job showing that they didn't put the right picture on this thing. But you can utilize a non-rebreather if you don't have one to improvise. This is oxygen humidifiers, usually indicated for long-term oxygen therapy. Sterile water reservoir is needed. So you may take a patient on a transfer sometime with this. If it's short transfers, you don't need this. If you're doing like a 2-hour transport and they're on oxygen, they're always on it. It doesn't hurt to have it. I don't know many ambulance services that carry this now. Heated humidified oxygen works really well with hypothermic patients though, but you have to have the heating system. I don't know of any, I don't think Maine even approves it to keep them on their trucks. I know New Hampshire doesn't either. So
Maine has it in their protocol for, I think, croup, but we all just use nebulized saline.
yeah, that's the best way to go. But heated humidified? No. So I know one town in Maine that had heated humidified, it was donated, but then Maine EMS saw it sitting on the truck and they told them to take it off. It's not an approved device. So, but yes, this humidified oxygen works for any kind of humid, like aerosolized medication like that. Works well for croup, though. You're all right. And if it's not working, then you need a paramedic. They can do a nebulizer or a ischemic epi to help open up the airways that way. Assisted and artificial ventilation, 100%. This is your BVM. All right, or we can do CPAP. Now, depending on the device you carry, some have what they call a FiO2 meter or regulator on it. FiO2 stands for fraction of inspired oxygen. And you can set your percentage of oxygen that the patient's actually going to receive. Remember that 21% is normal air, 100% is the highest you can go. I like FiO2 because I can tailor it to what the patient actually needs to meet SpO2 and oxygenation instead of giving them 100% all the time. The oxy peeps back in the day, CPAPs, used to have that regulator on it. You could make that determination of where you wanted to sit for the FiO2. Now, a lot of these Pulmodine systems you guys are utilizing now, I'm pretty sure a lot of you guys probably carry that in your truck as Pulmodine. That seems to be a common one. The PEEP is regulated by how much liter flow is actually going in. What was that?
I gotta head out again.
All right. So that kind of depends on what system you have. I'm not going to teach you all the different CPAP devices that are out there, but I would highly recommend that you learn the ones that your services carry and how you use them. There should be training ones available. So what we're going to do for a BVM, we're going to place it over the mouth and nose. After 5 to 10 breaths, slowly adjust the rate and deliver the appropriate tidal volume. So how do we know what tidal volume we need to give them? Is there a way to measure it? How do you know they're getting enough tidal volume? Is anybody still there?
Enough chest rise and fall?
Yeah, chest rise. That's it. Awesome. We can also monitor end tidal monitoring too. Right. So here's the difference. The table here you guys can look at for the difference between them. Normal ventilation versus positive pressure. This is mouth-to-mouth ventilation. This is a one-way valve, protects you from getting vomit or any other kind of communicable disease or into your mouth. You guys should be familiar with those. All right. To increase oxygen concentration, administer high-level flow oxygen at 50 liters per minute through the oxygen inlet valve of the mask, if you have a mask available for it. I don't know why they were showing these. These are barrier devices. This is mount the mask. This is the BVM. Again, if you guys want me to go over this in detail, I can, but I'm pretty sure you guys all know what a BVM is. You're in a dance school. All right. Very important to make sure that you are ventilating appropriately. That does not mean you need to squeeze the entire bag. You're doing just enough for chest rise. This is your oxygen reservoir here. So when you squeeze the oxygen out and you let it reinflate, it pulls oxygen from here into the chamber, and this refills back up with your oxygen inlet. Okay. Now, here's the only thing I'm going to make sure you guys add to these when you're BVMing somebody. Okay. Put end title mainstream on this right here and monitor end title. All right, so components, obviously we went over all these different things that were there. I just showed you guys all those. Technique. Okay. Quick forceful delivery bypasses the trachea, goes into the esophagus, causing gastric distension, which pushes up on the diaphragm, making it so you cannot do, which makes it harder for either the heart to pump or your CPR becomes more ineffective because of it. Right? Be conscientious of the rate of delivery of breaths. Right? I see this happen a lot where they're just bagging, and you're like, whoa, slow down a little bit. Right? Count to 10, then breathe again. Why so slow? Well, we got to control out there where you just did to the patient. Really, it's one breath every 6 to 8 seconds. Right? It's not too hard to ventilate. And that's going to be, I'm not saying that you guys don't know how, but as advanced EMTs, you're not running the show if you're on an advanced level truck. So you have to be able to oversee everything. You have to have that good scene management and good resource management. And what you have doing what? And watching everything that's going on while still doing your job to treat the patient. Right? So to do this, we're going to kneel above the patient's head. We're going to hold the mask in place. Right? This is called the double EC method. So you see the E here, the three fingers, right? Or the throws down there. And here's your C here. Double clamp holds it down very well. You see these little spikes on this, right? This can actually be used as a CPAP mask also. It has the 4 connectors on it. You can actually strap that to the patient's head. Right, we're going to ventilate the patient. And we'll do more of this in practical sessions as well. All right, here's the EC method here. Here's your C. And there's 3 fingers back here that wrap around the jaw. This is a manually triggered ventilation device or a flow restricted oxygen used to ventilate apneic or hypoventilating patients. Right? We are not carrying these in the ambulance, but it's called a flow restricted, a FROP, for the name for FROP. Or MTV, which is a manually triggered ventilation device. Right. So I see more of these in the more of the hospital use, like in the ORs and things like that. But working in ER, I've never had to use these. On the ambulance, we never had these either. At least not for me. But they have a demand valve triggered by a negative pressure generated by inhalation. What would use these in the ambulance, though, as far as for pain treatment, is they have these regulated devices for nitrous oxide for pain management. So not a lot of services do carry it, but if they do, then you might have those in the bag to be able to measure. It's not just a free flowing device. You really have to like negative pressure, take the hit on it, and that's how they get pain management that way. right? This is a transport ventilator, what they call an EMV, or they also have the one that are blue as well. But this is a Zolvent. It allows you to do precisely set ventilator rate, tidal volume, and peak inspiratory time. I am not teaching a vent class. These are the vents I'm very familiar with. So if you ever want to learn about them another time, I can teach it to you offline. But I'm not going to go in detail on how these ventilators work. You really don't have to know much about these. So you're not going to be tested on them. But this is what they call a transport ventilator. So steps for this: attach the ATV to the wall-mounted oxygen source. Remember how I mentioned before how you disconnect the flow regulator and attach a line right in? That's what I was talking about. So up here, this green part here comes off, and then you'll screw on a hose line, oxygen. It comes off like this, right? And then here, and there'll be a quick connect male adapter that looks something like this. And that connects directly into the wall of the ambulance. Or they'll have a pigtail coming off an oxygen bottle, and that'll connect two quick connects together like this, and they'll connect in place. All right. So once that's there, you'll have, you see this silver piece here? That's where the vent tubing will come off, like this, and I'll go to the patient. And then there's two more little devices here, and those are going to hook in your oxygen line and your pressure line. Those will go on the low pressure line will go on this side over here. There we go. All right, that's a vent. So most models have adjustments, respiratory rate, and tidal volume. You can control PEEP, PIP. There's all these different methods that you can utilize with this. FiO2, tidal volume, you can change it all. All right, so CPAP, something you're going to be using. So it's a non-invasive means for providing ventilatory support for patients in respiratory distress. Right, so early intervention with CPAP is an alternative mean providing ventilatory assistance, and it can prevent the need for endotracheal intubation. So I kind of covered this a lot with you guys. I have another CPAP class that we can add into the curriculum that'll go more in depth in a couple of slides. And then Laurel will cover more CPAP stuff with you guys during your practical sessions. Right, so indications for CPAP, patients experiencing respiratory distress, right? So things you can use it for, COPD, CHF, or different things you can utilize CPAP for. But in conjunction with these, right, we'll line across this, nitrates or dilators. So bronchodilators for this, nitrates for this. Nitrates make a bigger container and help push the fluid out into the vasculature, causing vasodilation, where this causes bronchodilation here for COPD. And you can inline the albuterol with this for COPD with the CPAP. Where CHF is, though, the only thing we have the ability to administer as the advanced EMT is nitro. Unfortunately, you got to move the mask out of the way to continuously give nitroglycerin, unless you have a nitro paste you can put on their chest. So some guidelines: patient has to be alert and able to follow commands. If they are unresponsive, they cannot receive CPAP. If they cannot maintain their own airway, they cannot receive CPAP. If they're that bad, BVM, OPA, call or drop in if they're unresponsive and they have no gag reflex, you can utilize like King's and or a high-gel. CPAP, pulse oximetry reading less than 90. Okay, rapid breathing rate. Of 26, more than 26 breaths a minute. in respiratory distress after a submersion incident. So they have trouble breathing and they've had a submersion incident. So I can let you guys know that one there. They now have water in their lungs. And Maine actually has a drowning protocol that has that in there. Contraindications, unresponsive, unable to speak or sit up, unable to protect their own airway. Respiratory arrest or agonal respirations. They have to be able to be breathing on their own for this to work. Hypoventilation, if they're breathing too slow, or hypotension. Hypotension is because it's putting barotrauma on the chest, causing the blood pressure to drop. Right? If they have a pneumothorax, facial trauma, chest trauma, closed head injury, or they're in cardiogenic shock. Right? If you have any of these, the patient cannot receive CPAP. If they have a trach, it's not going to work anyways. There's already a hole down there, right? So we can't use it for trachs. All right, if they have an active gastrointestinal bleed, nausea, or vomiting, why is that?
Just gonna push all that stuff back down there.
And also into the airway, right? Now we cause a chemical pneumonitis, which turns into a pneumonia, and the patient becomes very sick. All right, this one here, excessive facial hair. If you can't get a good seal and it leaks all the time, it's just not going to work. This might as well put an iron breather on at that point. Inability to properly fit CPAP system. Your CPAP should have different size masks or different devices. Or CPAP, like they have pediatric, child, adult, large adult, or small, medium, large, extra large masks with one system. Just figure out what you guys run. You should be able to have it for most patients. That are there. Right? So the patient exhales against resistance called positive end expiratory pressure. So CPAP is continuous positive airway pressure, where PEEP is positive end expiratory pressure. So this is composed of a generator, a mask, and a circuit that contains a corrugated tubing and a bacteria filter and a one-way valve. Right? So patient exhales against resistance called PEEP. PEEP then maintains pressure in the lungs at the end of exhalation and keeps the alveoli from collapsing. Some CPAP methods have PEEP valves that connect separately. All the ones that I've seen are all kind of integrated now. PEEP is controlled by manually adjusting a PEEP using a manometer or a predetermined by fixed setting on a PEEP valve. Now, some devices are controlled again by the control PEEP is done by liters per minute flow. So you have to know which device you have. There are other ones that are out there that have a valve that you just turn on the front of the mask to set where you want to go. So again, learn your systems. Most CPAPs are powered by oxygen, but the one thing you got to remember though is proper planning, because oxygen consumption is necessary for this. It uses a lot of O2 because it's going at an FiO2 at 100%, so it's using a lot. Right? Patients may feel CPAP claustrophobic. This is why I let the patient do it to themselves. And once they realize that it is working, they'll allow you to attach it to their head. Other complications, a possible cause of a pneumothorax. You can cause a pneumothorax as a result of barotrauma. Increased pressure in the chest cavity can also result in hypotension, all that pressure that's in the chest. Gastric distension, likely to occur if excessive pressure is used to inflate the lungs. That's why we keep talking about find what works for the PEEP for that patient. It pushes the diaphragm upward into the chest. So signs of that would be obviously distended abdomen, inability or increased resistance with a BVM, or increase in diameter of the stomach. Laryngectomy, tracheostomy, stoma, tracheostomy tubes. Right, these are all surgical procedures in which the larynx is removed, or a procedure performed by making a tracheostomy, creating a stoma. Very special consideration. Suctioning with a stoma, performed with extreme care. And I will tell you this, with stoma suctioning, If they are coughing up mucus, it flies across the ambulance. Right? Suctioning limited to a stoma, no more than 10 seconds at a time. Right? Because if you fail to recognize the need for suctioning, also can result in extreme hypoxia. Right? So you've got to look at your stomas that are there and suction appropriately and make sure that stays clear of mucus. Mucus plugs can kill people because they don't have the ability to oxygenate. All right. This is a stoma, as you can see here, placed through the skin, through the cricothyroid membrane, goes in. Oh, there we go. And we ventilate through here. If they have a trach tube in place, a lot of times these are kids that have them. They're on long-term ventilator, the long-term sickness, or on vents at home. In New Hampshire, as an EMT basic, you can transport a ventilator if it is a home vent. You do not require it to be an advanced EMT or a paramedic. All right. Tracheostomy tubes require a 1522 adapter to be compatible with a ventilatory device. That's the adapter at the end here. Right? Ventilation is accomplished by attaching a bag valve mask to the 15mm adapter under the trach tube. Dental appliances can cause airway obstruction. If they got false teeth, take them out. Right? Get them out of the way. Please don't lose them, though. Put them in a container. Right? You should take those out, get them out of the way. It allows you to have less chance for airway obstruction. Facial bleeding. So controlled bleeding with direct pressure and suction. Facial injuries are also associated with high suspicion for cervical spine injury. So when inserting any type of airway device, maintain inline stabilization of the cervical spine. Foreign body. Right. Adults usually occurs during a meal. A child occurs while eating, playing with small toys, or crawling around the house. An unresponsive patient, the most common obstruction is the tongue. Right? How do we displace the tongue in an unresponsive patient? Head tilt, chin lift, jaw thrust, OPAs, as long as they don't have a gag reflex. All right, you guys already know how to do all this stuff anyways. If the patient's not unresponsive, begin CPR as part of your BLS. All right, any questions so far? We're just going to finish up, no more breaks. We're about 15 slides left, so let's finish up. Then I'll have your quiz posted tonight at 10. So the King LT airway, this is what they call an SGA, or supraglottic airway device. Right? It's latex free. It's single use. Please don't take it out, clean it off, put it back in your bag. Right? It is done after you put it in someone's mouth. Single lumen airway blindly inserted into the esophagus. This part here goes into the esophagus. This part here inflates in the oropharynx, blocking the esophagus, blocking the upper part of the oropharynx. You ventilate through here, and air comes out here, oxygen. In theory, this pushes it through the glottic opening, which should be sitting right about there. Right? Please check the inflation of these. I have had many of these come defective. Before I left Action Ambulance and came down to where I am now, I took these off the trucks and went with eye gels because there's no inflation, and just slip it in. It's a lot easier, right? I found these to have holes in them. Usually a slice somewhere. The teeth can also break these too if you're putting them in through. So again, there's other room for error. But again, these are called supraglottic airways. Helps retain a patent airway in unresponsive patients who are breathing spontaneously. They also work in cardiac arrest. Right, this is a BLS skill in New Hampshire, and obviously ALS skill for Maine. So you guys become advanced EMTs, you'll have this ability. So as you can see here, it's placed in oropharynx, esophagus. There's your trachea right here, and the air goes and is delivered in. Oh. So we're talking about here, the King LTSD, the distal end is open. That allows for paramedics to place, there's an opening up here and an opening down here at the distal end of the tube. And we can put NG tubes or OG tubes down the tube itself and out. That's the ability. And the iGels have the same thing, but it's used for OG tubes, something that you guys can place. Most paramedic services that I've seen, if they have these, they have the King LTSD for the distal end being open. So alternative to back valve mask ventilations when a rescue device is required for failed intubation attempt. Contraindication, do not protect the airway from events of vomiting and aspiration. It does not work that way. Should not be used in patients with an intact gag reflex, patients who are known as esophageal disease, or patients who have ingested caustic substances. Okay, we don't want that to come back up and burn the airway and the esophagus. All right. Complications, laryngeal spasm, when the larynx spasm and closes shut, vomiting, aspiration, right? Possible hypoventilation. Please do not waste time trying to put these things in. Because I see people do this and they sit and get fixated on this. And what's not happening? We're not ventilating the patient. That's the key thing, is airway management. We're so focused and fixated on ALS intervention when the BLS intervention probably worked fine. Right? I'm not saying don't intubate. I mean, I'm rephrasing it, put SGAs in. What I'm saying is make sure that you're paying attention to airway management. So trauma results from improper insertion. I've had to take these out before and intubate patients because they have spent so much time forcing this in that they cause the airway to start bleeding. Okay, so lubricate, let it sit in, make your inflation, start ventilating. Don't shove the thing in like this, trying to get it through the mouth, because literally that tip at the end is pretty solid. You'll start tearing up the airway and the soft tissue, right? If the pharyngeal balloon pushes the epiglottis over the glottic opening, it might be very difficult to ventilate. So overinflation is also bad because it can do this. We run by patient's height and weight to determine the size of the airway that we need, right? So with the Kings, it's done by weights, height, and iGels are done by weight. So Kings are height, iGels are weight. And weight is done in kilograms. So you have to convert everything. All right, this is an LMA. I don't see these much on the ambulances anymore at all. More LMAs are utilized now for like ORs and things like that. It's called a laryngeal mask device. Literally, it comes in, the mask sits here, you inflate it, the distal tip goes in the esophagus, and airflow comes through here like this. Advantages: provides better oxygenation. Ventilation does not require continual maintenance of the mask seal. Insertion is definitely a lot easier than the King. Less risk of soft tissue injury, vocal cord, tracheal wall, or dental trauma. Provides protection from upper airway secretions. Again, not many services carry the LMA. They've gone through the iGel, which actually we're covering here in 2 slides. So it does not provide much protection against aspiration, as does endotracheal intubation. It's still considered the golden standard for ET tubes, but again, advanced EMTs can't do it. So learning these SGAs, they work well. SGAs work very well. Indications: patient cannot be intubated. Ineffective ventilations requiring high pulmonary pressures, or less effective in the obese patient. Right? This is what an iGel looks like inflated. Right? This is the distal tip down here. Keep in mind that these take higher numbers of mLs of air to be able to inflate these up. All right, next slide, iGels. What most people are going to. A lot of services in Vermont, pretty much the whole state went to these. A lot of services in New Hampshire, Maine is switching over because There's really nothing to it. You find the patient's weight, literally lube the tip of this, and you slide it in. It slides in, it sits right over this little tip, goes in the esophagus. Here's your oropharynx, and you literally ventilate. There is usually this one doesn't have it on there, but there's usually a piece, devices is this, it comes up on both sides like this. There's a band that goes around the back of the head, and it kind of hooks in and holds it in place. If not, you can tape it down too as well. This is what they call a Cobra PLA. I have not seen these things in a very long time, but your services may. I can tell you in New Hampshire and Maine, they don't carry these. But it's a supraglottic device with a tube for ventilation. Right? Again, recommended use for only patients who are not at risk of vomiting. As you can see here, it goes in. Here's your inflation here, and you ventilate. The next one used to be a New Hampshire one for EMTs, went away a long time ago, is called the combi tube. The combi tube is interesting because you can either intubate with this or put it down the esophagus. And that determines which one you're going to ventilate in. So you inflate them both. This tube is super hard. This is made of latex. So, and we're latex free. They pretty much got rid of these. But literally you shove it in the airway gently. If this went down in the trachea, then you ventilated like tube number 1. If it went down in the esophagus and you inflated this, all right, then you went to tube number 2. One of these, there's little dots through here. You can kind of see those. Those are ventilation holes. And you can ventilate through here, kind of like the King does. But if you intubated the patient and it goes in place, then you'll ventilate through here instead. And that's based upon which one you're using, 1 or 2. Again, though, very rigid. As you can see here, contains 2 different lumens. Either you're going to put it down in the airway and it goes in the esophagus, or you'll put it down in the airway and it goes down the trachea. You don't know, it's blind. So you have one or the other. But it accommodates any ventilation device. Indications: airway management of unresponsive apneic with no gag reflex cannot be used in pediatric patients younger than 16 years old. That's pretty useless, huh? 5 to 7 feet tall. So there's a lot of limitations to this, right? As far as contraindications. Combi tubes and King Airways can go down to the pediatrics, where this cannot. So these became pretty much useless and taken off trucks. Unrecognized displacement of the esophagus, laryngeal spasm, vomiting, possible hypoventilation, trauma to the pharynx, esophagus, or improper insertion technique. Let's see. Insertion techniques, again, we already went over this already. Checking both cups, confirm chest rise and presence of breath sounds. Let's see. Assisting with placement of advanced airways. Paramedic performs the skill, but the AMT partner plays an essential role. Helps set up for the procedure, performs BLS airway and ventilation, helps monitor the patient. As far as advanced airway goes, not paraglottic, but supraglottic airways. As an advanced EMT, you have those eye gels. LMAs are still part of it, but no one really carries them anymore. And King Airways. Right, if you're in New Hampshire EMT, you have that already at the EMT level. You should already be trained in them. Right. ET intubation. This is a paramedic skill. Insertion of a tube into the trachea to maintain and protect the airway. Patient prep, pre-oxygenation. Right. We don't do a ton of it. We're not RSIing a patient. Right. We're just putting an intubation tube in. But we're going to pre-oxygenate a little bit, so we'll probably put them on a nasal cannula along with another breather, or we can ventilate a little bit more. It's what we call nitrogen washout. We basically push all the nitrogen out of the system. We over-oxygenate. So that way there, when we're trying to get a tube and they're not breathing for 30 seconds, we have time. All right. So nitrogen washout happens here. We then intubate. If it takes more than 30 seconds, we need to stop and go back to ventilating or go to a rescue airway. And we do apneic oxygenation. BVM, 100% O2. Or in New Hampshire's case, since this is a New Hampshire class, the paramedic, if they have a vent on the truck, and put them on a ventilator. So we don't have to do BVM at all. So there's different types of laryngoscopy that we can use, laryngoscopes. There's direct, which means we come in like this, we lift up, and we look directly at the upper the glottic opening. Or we have something called video laryngoscopes, where we actually come in and look at a video screen. Right. So 2 different options you have there. Intubation equipment and sets include personal protective equipment, including appropriate face mask and eye shield. Definitely needed because patients vomit and spit, and things happen. Suction unit with rigid tonsil tip. Right, this one here we utilize for what they call a salad technique, or a whistle tip catheters to be able to go down the tube to suction. Laryngoscope blades and handles. Really? Laryngoscope blade and handles. There's 2 different types. There's what they call Mack and Miller blades. There's other ones out there too for hyperangulated. We're not going to get into that. Mack and Millers. All right, Mack, think of a Macintosh Apple. It's curved blade. Miller, think of like Miller. It's straight up and down. McGill forceps are used for patients that have foreign objects in the airway. It's like a big pair of weird looking scissors with like a grip at the end of it. And they have to use a laryngoscope to come in. They go into the McGills. They pull out anything deep in the airway. ET tubes and a stylet or tube introducer. Another name for a tube introducer, and you guys have probably heard this before, is called a bougie. All right. So that's the difference things with the assisting with the airway. Assisting with placement here, you have to have a water soluble lubricant. We have to lubricate the tip. A 10 ml syringe. A 10 ml syringe that helps fill the cuff. We want to make sure you check that first. A confirmation device. And the confirmation device, by the way, is the same thing you guys should be utilizing for your eye gels and everything else. It is colorimetric. I don't even go to those anymore. Right off the bat, I go to including waveform and title. That's already on the patient. There's nothing more confirmation than having waveform. You can do the yay for yellow colorimetric, but it doesn't really matter. I always write to end title. Commercial ET tube securing device. If you don't have one, you can use oxygen tubing too, as an option. Or alternate airway management device, such as a supraglottic airway or a Crate kit. Let's hope we don't have to go to this one here. If I'm intubating, I always have an iGel or a King ready to go. So if I have a failed attempt and I can't get a tube, I'm dropping that in. All right. But with video laryngoscopes nowadays, it's pretty hard to miss now. But again, it's practice and repetition for medics. All right, and last slide here, something called B Magic Mnemonic.
Kevin,
was that?
I have to head out.
All right. So the B Magic, perform back valve mask pre-oxygenation. This causes the nitrogen washout. Evaluate for airway difficulties. We look at what they call a Mallampati score to find out if it's 1 through 4. Looking at the potential difficulty of an airway. There's other methods we can utilize too. Manipulate the patient if we need to. The best way to intubate somebody is take the head of the stretcher, go up to 30 degrees like this, and then you get a better view of the cords. Attempt first pass intubation. A lot of services don't allow intubation to happen now unless you're using a bougie first. Another area it's almost guaranteed 100% success that way. GI or supraglottic or intermediate airway if unavailable. And C, confirm successful intubation, correct any issues. Epigastric sounds, negative. Lung sounds, positive. Equal rise and fall. When we get the number at the teeth where the tube sits, and we secure it there. So that's intubation in a nutshell. All right, so do this here.